possible.
Absolutely.
All right, so I think we should be starting now. Okay. Akram, I think we're all set.
Yes, sir, we can start.
Hello, everyone, and good evening. Very warm welcome to this second annual EP Fellows Summit. Like last year, this year too, we have had some great response, rather overwhelming response. Out of 30 plus cases submitted, 16 have been chosen for presentation in this summit. The selection of the cases by the moderators was not necessarily based on the complexity of the case, but the way the presenter has analyzed the data and has discussed the differentials and the management options. Selection of the cases is also from the point of view of covering as much electrophysiology and the device therapy issues as possible and avoid repetition. All the presenters are given a certificate and a cash prize of rupees 10,000. Those cases those cases which are not being chosen for presentation, I should say, they are also very worthy of going through. Now we'll start with the first set of the presenters, and it is my pleasure to invite the distinguished moderators. Dr. Yash Lokhandawala, I think every one of us are aware of. Dr. Yash Lokhandawala is arguably the most knowledgeable electrophysiologist in the country, according to me. He has trained not less than 100 EP fellows so far, and he's the president of IHRS currently. He also is a consultant cardiac electrophysiologist, Holy Family Hospital, Mumbai. So I warmly welcome Dr. Yash. Dr. Nitish Bhador, I'm sure most of the attendees know him very well. He is one of those electrophysiologists from US who frequently comes to India and trains most of us. And he's a most sought after faculty in the EP conferences in the country. And I have a special bonding with him. In fact, I owe a lot, my department owes a lot to him for his guidance and continuous support. Dr. Shyam Kumar, most of the attendees who were there last time must be knowing about him. He's Associate Professor, Department of Cardiac Electrophysiology, Hamilton Health Sciences in Ontario, Canada. He's known for his extreme depth of the knowledge regarding the EP cases, the device cases. The way he analyzes, I think, is very impressive. So we are very proud here to have such distinguished moderators today to moderate the cases by some brilliant upcoming electrophysiologists. We will start with Dr. Anunaya Gupta, who is the EP Fellow, Westmead Hospital, University of Sydney, Australia. He actually hails from Delhi. He recently had joined Australia as an EP Fellow. So he's going to be talking about a young man with recurrent palpitations, double trouble. So I would like to make some announcement here. We should keep up the time, and each presenter is given 15 minutes. And just before the 15 minutes or 2 minutes before the allotted time, there will be a buzz. So the presenter can quickly wrap up his presentation. So exactly within 15 minutes, the presenter completes his presentation so that the moderator will discuss and make remarks over the next 10 minutes. So each talk is about 25 minutes, and let's try to keep up the time. I request the attendees to type in their questions, their comments, their suggestions, etc. in the chat box. Our moderators will look into that. With this, again, I welcome everyone here, and I request Dr. Ananya Gupta to start off this second annual EP Fellows Summit and moderators to take over.
A very warm good evening to everyone, and special thanks to Lars sir for considering my case. Are you able to see my slides, sir?
The slides not yet seen.
Yeah. Are you able to see now, sir?
Yes, yes, yes. And you can put it in the slideshow mode.
Okay, great. So a very warm good evening to everyone, and special thanks to Lars sir for considering my case for presentation. And so I will start my case among the masters. So this was a case of a young male with recurrent palpitations. So he was basically a 39-year-old male who presented to our outpatient department with recurrent palpitations. And he had an history of documented tachycardia, which was narrow QRS, short RP on ECG, and he had one ER hospitalization for the same, and received intravenous adenosine, which terminated the tachycardia. His baseline ECG showed no evidence of WBW syndrome, any evidence of short PR or delta wave. His ejection fraction was normal, and he had subsequently was taken for an electrophysiology study and possible radiofrequency ablation. So the problem we encountered was that we were not able to hook coronary sinus through both. We tried from femoral route using even SL0 sheath, and later on we switched to right intrajugular venous route. We tried multiple way to hook it, but we were unsuccessful. Later on, to define coronary sinus anatomy and CSOs, we thought let's take a coronary angiography. And what we found was when we took a coronary shot in the levo phase, there was no drainage of coronary sinus os at the normal position, and it revealed a coronary sinus os atresia. And two other things were a CS was draining into high lateral right atrium and a left atrium, which suggested an unroofed coronary sinus. And also, to our surprise, there was a big large diverticula from coronary sinus, which we thought that was likely responsible for this AVRT due to a bypass tract, and there was a small patent vein of Marshall. So this was the coronary sinus shot. This was taken a biplane cath lab. You can see this is my catheter at his RV apex, and when CS, there's nothing opening here, and there's a tiny venous drainage into high right atrium, and this CS is opening into the left atrium, and there's a big CS diverticula, and there's something tiny going up. In this RAO view, you can see define that pattern of vein of Marshall better. Yeah, you can see here there's some constriction happening here, and it's going up, and there's a big large CS diverticula here. So we thought what were our options in this case? Because without CS, we thought less likely that the diverticula is in this patient is responsible for this AVRT. So first of all, there are two things. One is patent vein of Marshall versus patent left superior vena cava. So this patent vein of Marshall is now being more and more discussed due to being used in AF ablations, and especially in persistent AF, and those drivers arising not from the pulmonary veins. And it was basically in the literature, you will find it many a time patent vein of Marshall mentioned at small persistent LSVC. They both connect left subclavian to mid coronary sinus in the area of Wilson's wall. The size of the persistent left superior vena cava is determined by the amount of flow from the subclavian to the CS, while it's reverse in the case of patent vein of Marshall, and it will determine in the reverse direction, which will happen from CS to the left subclavian. And a patent vein of Marshall is usually find with CS abnormalities like CS atresia, unroofed CSN. And the important thing is that with persistent left superior vena cava, the distal CS and CSOs will be usually enlarged because the blood will come from away to the downwards. So we thought that let's attempt it from if we can insert our we thought that we have a small 5 French catheter which may go through this patent vein of Marshall, and we can attempt this. We can go at the neck of the diverticula and ablate it because we are unlikely to take an irrigation catheter, which is usually of larger diameter and larger French. So we first went from the right groin and just defined this patent vein of Marshall and tried attempting inserting our sheath and followed by this ablation catheter, but we were not able to negotiate it. So we took a shot here also, and you can see this vein of Marshall is very tortuous, having many bends and a few constrictions also. Then we could clearly demonstrate that it was a case of unroofed coronary sinus OS with this vein of Marshall coming, joining coronary sinus, then opening in left atrium, and then going to right superior pulmonary vein into the pulmonary venous system. Then we thought because that curve was not allowing us to go inside, we took a left interjugular venous axis and took a small 6F Cook long sheath, and then we took, as you can see here, this clear diverticula and it can be seen. Now coming to the EP study, as you can see here in this is baseline ECG, there is no evidence of pre-excitation, and we can find a incomplete right bundle branch block at the baseline. Baseline intervals were within normal limit. There was no evidence of any pre-excitation with a normal HV and AH interval. And we have to understand that the CS12 is not now at the poles which are at the origin of the CS, and 910 is at the basically distal, so reverse of what we normally see in clinical event. So this is the proximal C and distal CS, and you can see here this tachycardia was easily induced with ventricular extra stimulus. And there's a varying aberrancy here, which now finally settles out. As you can see here, the CS12 is early. And so this was the spontaneous termination, which proved that the left posterior-septal pathway is the part of the circuit. Now coming to this tracing, you can see here that there's baseline right bundle branch block, which during tachycardia, this aberrancy worsens and the HV intervals remain positive, which favors it being an aberrancy. And now here in this penultimate beat, you can see there is a fusion happening, suggests a likely a spontaneous PVC, which likely at the time at the level of his, and it advances next day. Then what happens? It goes up, and it basically with right bundle and left anterior fascicle both were refractory, and it peels off the refractoriness of the left anterior fascicle, and later on normalizes the QRS, and the tachycardia terminates in the AV node. This you can see here that difference in the CS myocardial extension potential, which is very sharp, and the initial one, and the later far field, which we can see from the left atrium. Patient was having multiple episodes of frequent AF, which also further suggests a more common in the patient with WBW. And the tachycardia was then finally degenerating into this AF was degenerating into the tachycardia. And apical pulses wave spacing also proved the existence of the pathway. Then we attempted inserted a 5 French catheter and took to the neck of the diverticula and ablated during the RV pacing. As you can see here, this A signals, which was fused at ablation distal much earlier than the His proximal, and supposedly a pathway potential is seen, and then A disappears. And post-ablation, there was no evidence of pathway conduction, both by para-Hisian pacing and with adenosine. They were both AV and VA block. So the learning point from this case are CS atresia is a rare venous anomaly encountered during usually CRT devices, and there are a few cases during EP study also. And combination of CS atresia and large diverticula is an extremely rare combination, which basically makes endocardial ablation nearly impossible. And there's only one case report which I could find in the literature. Patent vein of Marshall versus patent small persistent LSVC should be differentiated by the flow of the blood. And a vein of Marshall helps us to engage the coronary sinus and later help in successful ablation of the pathway. These patients usually will require epicardial ablation if endocardial ablation is successful and there is recurrence. And understanding coronary sinus venous anatomy is critical, and we should take no time in taking a coronary angio shot to define the coronary sinus anatomy, especially with posterior septal accessory pathways. And partial unroofing of the coronary sinus and drainage into LA can be an unrecognized cause of stroke during the procedure, because it's like a transseptal puncture. So a proper adequate heparinization and ACT monitoring is must. Thank you.
Over to the moderators. And I invite the attendees to type in their questions, remarks, please.
So can you show your slides? It's a very nice presentation of how you cannulated the CS from above.
Sure, sure.
I wanted to ask you a couple of things through your.
Yes. So are you able to share? See?
Yeah. So one thing I wanted to ask you. So you're showing. You go to that slide where you're showing the pulmonary vein.
Yeah.
So that means you are entering the left atrium from the coronary sinus, right?
Yes, yes.
So technically, you could do a transeptal puncture and enter the coronary sinus from the left atrium.
Yes, we thought about that. We thought that it may be difficult to loop the catheter. Yeah, we thought about that day.
Because I think you don't have. Show me a shot of your diverticulum through the thing, because it's very hard to stabilize a catheter over there. I'm surprised that you're able to go from above and stabilize it.
It's better seen in this RO.
Okay, so can you show us where exactly you were successful in?
Yes.
When you cannulate through the CS, I think you have a better shot of the.
Yeah. So basically here, at this point where his catheter was crossing, and this Cook sheath could come up to here. Then we have to give some clockwise anti-clockwise twist to just stabilize it here. And this point at the third electrode of the his where the junction neck was.
Right. Yeah, I mean, I think you are showing cannulation of the CS through a vein of Marshall, which was bigger than usual. Usually, it is always there, the vein of Marshall.
Yes.
That's why these people are doing, but it's very hard to cannulate it from above. You were lucky that it was big over there, and these necks are very hard to get even from a patient who has a normal CS, because you really have to map the KP. But looks like you must have been successful right at the neck here, right?
Yes, this one, this point.
Right, exactly. Now, yeah, I mean, I think it's very, it's a very interesting anomaly that this patient has, and you were able to get in from here and do that. One thing I think, as you must have read up in the literature, is that one has to be very careful doing this, right? Because if there is any perforation, you're going to have cardiac tamponade.
Yes.
Right. So people have inadvertently, tried to cannulate the left IJ for some other reason and landed up with tamponade. So let's go to the EGM part.
Yes.
I thought there was something interesting over there also.
Yes.
So a couple of things. Yeah, let's go to the next slide. Yeah. So I think it's good to just go back to that one. It's good that you had you are explaining that CS1 and that is different, but it might be useful just to relabel the CS.
Yes.
Right?
Yes.
Because otherwise you are going to anybody who's looking at it will be looking at it upside down. This slide I think is useful. You also have a slide of initiation of TAC, right?
Yes.
So this slide I think is more powerful than the other slide in terms of making a diagnosis, because just by this initiation you have sort of made your diagnosis. You understand?
Because this this goes with A. This extra stimulus go up with A. Then there is a it initiates with the left bundle branch aberrancy.
Right.
Then goes back into the right bundle.
Right. So first of all, you initiate with the VAV, right?
Yes.
So you rule out an atrial texture. Yeah.
Right.
And then the left bundle branch block aberrancy is helping you, right? Because
Yes.
the VA is longer, whereas the VA in right bundle, which is his normal thing, is short.
Yes.
So that is how you root out. Otherwise, you cannot say, the differential of AV and RT is always there, right? In this case.
And PPI TCL is also short, so it suggests if we
Yeah, PPI TCL, I don't know what you can do with A1B tachycardia with short RP. I mean, this is a short RP, but I think this is a more powerful thing. The VA
Yes.
getting long with a left bundle versus a narrow is something that I think in this case CS34 is where your pathway is on
Yes.
your electrode.
Yep. Sir.
So I think that is something very important to point out. This slide really gives you the diagnosis. There is nothing else. And then if you go to the next slide where you were pointing out the V on his, I think that's a good finding. I think the next one is right. Yeah.
Yeah.
So it's a good thing that you commented that this is a V on his coming from the RV, the his catheter, right? The
Yes.
second last beat.
Yeah.
The only problem is that it proves the pathway is present, right? It pulls in the A, but it does not pull in the subsequent V. In fact, it pushes out the subsequent V,
Yeah.
right? And that is why your QRS normalizes, because it
Yeah.
normalizes because now there is enough time for, the retrograde invasion into the right bundle is gone away because you've given enough time for the AV node to conduct with a long, and probably that is why it terminates also.
Yes.
Because it slowed down the antegrade limb. But I think it's a good finding that spontaneous PVCs should be picked up, especially a PVC that happens to be V on his. So that I think was nice that you nicely pointed that out. But again, this is just suggestive. What you saw in the previous slide with the left
Yes.
bundle is absolutely diagnostic.
Yes.
Right? That's the Kummel's rule.
Yes.
Okay, let's go to the next. I think that's pretty much, and I think go to the slide with your termination or with your ablation.
Yeah. Yes.
So this is AFib. That is good that you don't have antegrade. Yeah, so here I think I have some issue because if you look at the ablation catheter, you don't lose the A, right? The A is still there.
Mhm.
I think this is happening with the his catheter. It's probably moving back and forth. It's going more on the ventricular side. I mean, look at ablator distal and ablator proximal. I think you're going from predominantly atrial side to predominantly ventricular side. And the VA is still there. So you must not have gotten it with this. There must be some other, I mean, this VA is long, but then the next VA is short. So it's hard to tell here.
Right.
And I think it's really, I can understand what you're, I mean, this is a very complex signal. So you ideally, I don't know if you did it, but it's good to show at that spot. If the attack is very easily inducible, what is V and what is A?
Okay.
So then you can see that. It's very suggestive that what you have on the ablator distal might have some kind of KP. But it's not in these 4 slides that you got rid of the pathway because you still have the VA. I think you're just oscillating back and forth on the annulus.
Okay.
You must have needed more than one burn to get rid of this pathway.
Likely, yes.
Yeah, because these are very hard to stabilize. That's why I was wondering, going from above, you don't have any support. When we go from below in these cases where there are diverticuli, we really need sheets to hold it in place. The best sheet to get into the CS from below is actually the SL3 sheet. But I guess you guys tried that, and from the right atrium, there is no way to get in, right? There might be just a small cardiac vein or something that is going into the right atrium. I think those are the only things, but otherwise, and then the next slide is good. You have a nice demonstration of parahesian pacing. There over there. Yeah. I think ideally, we try to do it through a RV catheter, which we put at close to the his, so you can see it. But here on his proximal, you can nicely see the variation in the VA, which happens while the catheter moves instead of changing the output that much.
Yeah.
You can see that in between. So that's a very nice, clear demonstration of parahesian pacing. One other advice is that whenever you show these or when you present, always have a lead. One of the leads you should have, like instead of AVL, you should have probably a inferior lead. So
Okay.
people can tell exactly where you
Where
are.
are we placing? Where are we placing?
Sometimes you are placing the base or the apex or something like that.
Yeah.
But I think this is very nice, and it's a very nice demonstration of how you got into a difficult CS from above. And I'm glad you got rid of it. So
Thank you.
So Dr. Sam Kumar, you can pitch in, please.
Thank you. The great case, and congratulations.
Thanks.
It's an excellent demonstration of very adventurous ablation. I have a couple of questions and one comment on the slide you showed. One is, I haven't seen a concealed pathway which is located in the diverticulum so far. All the diverticular pathways I have seen are kind of manifest, and usually we go pre-delta where you go into the diverticulum. But did you map the atrial endocardium transeptally or retrograde or in any way and documented the CSEs earlier than the earliest left atrium? So I wonder whether you could have gotten this just by going, traditional endocardial mapping. So the second is, was there any problem in impedance issues with this catheter, especially the non-irrigated 5 French catheter inside the
Yes.
atretic coronary sinus? So did you map the left atrial endocardium at all, or you just went into the CA?
No, we didn't do transeptal puncture at all.
Okay.
We thought
Yeah.
that it will go by neck only. The easiest way to target a diverticle. When we found it a diverticular, we thought like the easiest way to target a diverticular is by ablating at the neck. And
Maybe I don't have any experience in concealed ones mapping inside the CS. We always go the earliest atria. The third point is the parahesian pacing you showed. I still don't know if it is truly a AV nodal response because the difference is only 28 milliseconds. So I don't know if it still could be a fusion. I would like to see a much bigger VA separation when you lose his bundle. It's 120 and 148. That 28 millisecond separation, a little bit, I'm not 100% sure it is a pure AV nodal response. It still could be a fusion response. I don't know. But probably you got it there, and it's a great demonstration.
So
thank you, sir. Thank you, Sam, sir. Thank you, Nitish.
Anunaya, it's a great case, from my side too. Please accept the congratulations. Your presentation is always good and a lot of things to learn. So with the permission from the moderators, may I invite now another international fellow, Dr. Ahmed Yassin. He is an adult cardiovascular medicine fellow from the Detroit Medical Center. He's going to be talking something to do with the LV leadless pacemaker in a patient with a complex congenital heart disease. So Dr. Ahmed, good to see you and warm welcome to this EP Fellow Summit. And I hope you would be joining us next time as a moderator or faculty.
Thank you. Thank you so much. Thanks for having me, guys.
Akram, can you share the slides, please?
Yes, sir. He can share notes.
Just 1 second. I'm trying to share my slides.
Akram, did we lose connection with Dr. Ahmed?
Yes, sir. I think he just went out and he's joining again.
No, he's back.
Sir, he can. Sir, you can share now.
I'm trying to share the slides.
Some hitch.
Yeah, it says host disabled participant screen sharing.
1 sec. You can share now, sir.
Yes, sir. All right, thank you everybody, and sorry about this small technical glitch at the beginning. My name is Yassine. I'm one of the general cardiology fellows at DMC, and we had this case we would like to share with you. Thanks for the opportunity. So we are presenting a left ventricular leadless pacemaker in a patient with dextro transposition of the great vessels, palliated with massive procedure. And I'm going to start with a few words about the Micra device. It's basically the new recent revolution in cardiac basing. It's a device in the size of a bullet, and it's usually get implanted on the RV septum. It's a standard procedure, usually the access from the right femoral vein, 27 French introducer, and then the delivery system through the introducer. And then when you get to the right atrium, you pass your delivery system and you deflect through the tricuspid valve. And then there, when you are in a good position, again, is the septum, you're gonna inject some dye to make sure you are in a proper position, not too apical. And then you deploy the device. And then basically after that, you check your basing parameters. And if you are happy about it and it's acceptable, you're probably gonna deploy your device. It came out as an option for in situations when we don't want to like in patients who have deemed to be complex or known to have some sort of like, for example, previous lead endocarditis, or even in patients who not necessarily going to require basing too much, or patients with the probably even AV synchrony not necessary, despite that Micra in fact can give you an AV synchrony as well, and VDD mood has been added. So there is a couple of studies about the safety and efficacy of the leadless pacemakers. I just cited here one of them by Len and his group that was published in JACC in 2021. Basically, they did a systematic review and meta-analysis of 36 study, and they pulled in data regarding complication incidents at 90 days and at 1 year. And it showed like the Micra was found to have a good basing captures at 1 year. And also they found that what was associated with 51% lower odds of complications compared to transvenous pacing. So going back to our patient, he's a 39-year-old male with a history of dextro transposition of the great vessels who get master procedure. So in transposition of the great vessels, it's basically you get your aorta coming out from your RV. So your RV is your systemic RV, and your pulmonary artery are coming out of your LV. So you have some pulmonic LV. Without correction, you have 2 parallel circulations. Life is impossible without shunting or correction. But the master procedure was basically very like the standard of care in the 60s when it came first, starting from Toronto, Canada, and then that was replaced later in the 80s by the Gayton procedure, the atrial switch. So the master is not it's not performed in the current era. Basically, they divert the cava bloods from the superior vena cava to the inferior vena cava through a baffle all the way to your subpulmonic LV, and that one will be working to pump the blood through the pulmonary artery to the lung, and then back again through the pulmonary veins to the right to the systemic RV, and then the systemic RV will be your systemic ventricle. So our patient, his story started when he was 7-year-old, and at that time it was a few years after he had his correction surgery. And he had at that time atrial flutter, and that was treated medically. He did well for a while. When he was 21-year-old, he came again with the syncopal attacks. He had multiple syncopal attacks, and this is his ECG. It's showing like first degree AV block with very prolonged PR around 400 milliseconds. And his echocardiogram, it showed like dilated RV, reduced function is expected since his RV is acting as a systemic RV. So he initially was given an event monitor to look if there is more than this. And his event monitor or Holter monitor showed there is a second degree AV block type 2, as well as this first degree AV block. There's certain poses as well. And there's one episode of non-sustained VT. So he was taken to the EB lab for an EB study that showed prolonged HV interval. And because given his cardiac history, given his congenital history, previous surgical history, and syncopal attack and non-sustained VT on the monitor, he like evaluation for inducible VT was reasonable, and that was the case. So he ended up getting dual chamber AICD, and that's the X-ray here on the side showing his initial dual chamber AICD, and you can see because the patient with this congenital anomaly, you can see his ICD leads with the two coils. It's on the LV, which is the subpulmonic LV, and this is his left atrial lead. He did well for a couple of years. He came later. Just before we go there, I just here added this slide to show how the pacemaker in this type of patient would look like. Basically, the two leads will go through the baffle, and the LA lead and the LV lead, which is this both are the subpulmonic chambers. So he came later, a few years later, with the symptoms of heart failure and fever. And he was found to have also bacteremia. It grew gram-positive cocci, and it was finally speciated to be Staph aureus. He get a transesophageal echocardiogram that showed multiple vegetations on the ventricular lead. So the decision was absolutely to take his lead, his whole device out, and treat him with antibiotics, of course. Meanwhile, to cover him, he was given a live vest, and temporary pacemaker, like permanent pacemaker, was implanted. And you can see here, this is his temporary pacemaker. There's a can out here, and the wires was cannulated under the skin all the way to his subpulmonic LV. So he finished his course of like 6 weeks of antibiotics, his like at home IV antibiotics, his symptoms resolved, his heart failure resolved, symptoms improved, his blood cultures were negative. So he was brought back at this time to removing of his temporary permanent pacemaker. And the decision was to consider the micro device despite the anatomical challenge, but it was a reasonable option for him, especially that he had the lead endocarditis in the past. And of course, the plan was for sub-Q AICD as well. So this is here a few pictures. I have it next on the videos. Basically, this is your introducer sheath. And then initially, that's just a gay like catheter with angiograms of the subpulmonic LV. And again, here, this is your micra getting out from the delivery system just minutes before deployments. And afterwards, this is here the device in the final shape. This is his temporary pacemaker that came out in the same setting. The micra was after it was implanted, it was programmed to VVI 60. We had a good R wave, 7 to 8 millivolts. His impedance was 600. Capture threshold was 0.35 volts at pulse width of 0.4 milliseconds. So this was acceptable numbers. Let me see next here. We try to play these videos, hopefully. Okay. So I'm going to play the videos out of my So basically, this is the initial angiogram in 2 views with a gay wire to define the anatomy and defining the septum. And next, the deployment system and passing the device again as a septum. And eventually, the last section will show you that the final results. So basically, when you are at that position here, for example, like after initially like attaching the micro to the septum, you're going to pull your catheter back, and then you check your parameters if it's acceptable. You're going to do your tug test and like pull on hold. You want to see the small tens coming out. One of the biggest challenge in this case was because it was in the LV, so there is less trabeculation than the RV. So that was some sort of challenging. I think the operator experience was of a great assess here and help to get the things done. And eventually here, after you're happy with this, you have to release your tether, and the system will be deployed. This is an X-ray both procedure. You can see this. This is the sub-Q ICD with the wire tunnel and the skin over here, and it's above the sternum. And you have your micro on here. And CT scan was done in a later admission for a different reason. You can see clearly in the septum on the subpulmonic LV, same wise here. And this is, I think, the clearest image for the device with all the expected artifacts to come with that. So basically, in 26-month follow-up, the pacemaker was intact. Capture threshold was acceptable. Most recent capture thresholds was around 1-fold at pulse width of 0.4 milliseconds. Impedance was around 700. R wave still at 6 to 7. It's a sentinel report of leadless pacemaker with subcutaneous AICD and subpulmonic LV. Challenges, of course, was the catheter or the sheath manipulation and passing the system through the baffle system, like the baffle that to be able to deploy the device in the right place. And of course, we highlighted earlier the less trabeculations on the LV site and compared to the RV site, which is the usual site of insertion for such devices. So conclusion is leadless pacemaker implantation is feasible in such a complex congenital heart disease patients. Appreciation of and understanding of the anatomy, it's very important. And of course, experience of the operators and anticipating complications is another thing to put in mind. Thank you so much, and I'm open for questions.
Okay. Well, that was a very elegant presentation of, going through the baffle to put in your micra. This has obviously been done in patients with, micra and sub-Q ICD has been implanted in people with, in the normal RV and that setting. I have a couple of questions for you. What are the challenges of ICD with the micra? So how did you test the sub-Q ICD?
Finally, like when you have, of course, you would expect some interference to happen since the micra is there. I believe what we did is after implanting the ICD, we looked for, we didn't do an induction to see if our ICD will be sufficient, or at least the shock will be sufficient. But some sort of, we were aware of that, a possibility of this interference.
So you have to, whenever you have, it doesn't matter you have a micra or a sub-Q ICD, if you have a regular ICD and a different pacemaker, you have to pace the pacemaker as the highest output and induce VF and make sure that the pacemaker output does not inhibit the VF detection on the ICD. Otherwise, the patient will go into VF, and the pacing stimuli, if they are inhibiting the ICD detection, the patient will not get a shock. So that is that is what is required. Whether you have a micro or a sub-Q ICD, or you have a regular pacemaker, and as long as they are two separate units, you have to do that, because the pacing stimulus can just cause that artifact. And the number two is sub-Q ICD is the only ICD implantation where I check DFT testing, right? And the other ones we don't, because you really want to make sure that that will, get the patient out of the thing. So I think that's an important point. The second thing I want to ask you is, when you were showing initially, so this patient's EF is low, I presume, and the RVEF, right? It's less than 35%. That's why you got that. So you are sacrificing AV synchrony, right, by putting in micra, because even the dual micra, the one which can sense the A but pace the V, does not have ability to go beyond 105 or something, and it has very weird algorithms that have to be programmed. So if this patient truly does develop AV block and requires pacing, so then you won't have that ability. You will lose AV synchrony in a patient with cardiomyopathy. So that's another issue that one has to care about, right?
The VDD like mode can be done by micra, where it's detect the atrial mechanical signals and it still achieve some AV synchrony. That has been
but that is limited. It only goes up to a certain heart rate.
That's right.
And it has also got a lot of issues when you turn that on. Sometimes in sinus rhythm, it starts pacing without that. So it is very limited, especially in a young patient where you want tracking. If he develops true AV block, you want him to track up to 140, 150, right? And this is a young guy. So that you won't be able to do with the micra that we have now.
Absolutely, it's a very good point.
But otherwise, I think, it's a good demonstration that at least the technique is difficult, because as you're pointing out, the RV trabeculations make it easier to put the micra in the RV, whereas in the left ventricle, and also to turn around the other way to put it in the septum, right? The septum is not the regular way. That is that definitely requires operator experience.
Absolutely.
It's probably Randy Lieberman did that, right?
Yeah, he's actually here listening to us today.
Yeah, he's a very good operator. I know that.
Dr. Lieberman, do you have any point to add?
Well,
yeah, I think.
I don't know if everybody can hear. The points that were brought up, we agree about the issue about potentially having to go to BIV pacing in the future on the patient. But we felt that at the time, since he'd had an infection, that the micras, as everybody knows, have a very, very low risk of infections. So we felt the trade-off at this time for placing the micra versus implanting a BIV system favored the micra at this time. Putting in a standard dual chamber pacemaker, once again, was just going to give him the dyssynchrony if we had to go to significant pacing. And then he actually did have VF testing for interaction with the micra. We agree 100% that you have to test these patients for interaction.
Dr. Sam Kumar, I think you are mute.
Yeah, great demonstration. I have a question, because the micra is actually coming within the shock vector. So are there any concerns of this shocks, damaging the circuitry? Because typically we have seen people externally cardioverting and frying the pacemaker generator. So is it a concern here, or it's not? I mean,
I think it, yeah.
So far, there have been no reported cases. I mean, this was part of the MICRA and reports at the time for implants with the sub-Q. So there's been no reports of pacemaker malfunction in the setting of a MICRA with a sub-Q.
So you go for sub-Q first or MICRA first here, and the DF testing was done with MICRA in place, or?
Yeah, so the DFT testing was done with MICRA in place.
Okay.
So I think it was a great case. Shall we go to the next set of presenters? We have the distinguished and very much acknowledged electrophysiologists who are going to be moderating this second set of presentations. And it's my privilege to call upon Dr. Channi Sriram, who is a consultant pediatric electrophysiologist from the Children's Hospital of Michigan in Detroit Medical Center. He's going to be accompanied by another very, very knowledgeable and arguably the most respected electrophysiologist of the country, Dr. Mohan Nair, who is the director and the head of the Department of Cardiology at the Asian Institute of Medical Sciences, New Delhi. He's going to be also joined by my friend, very distinguished electrophysiologist, very knowledgeable, and who also happens to be the editor-in-chief of the Indian Pacing and Electrophysiology Journal, Dr. Raja Selvaraju. He's the professor and the head of the Department of Electrophysiology at the prestigious Jawaharlal Institute of Postgraduate Medical Education Research, Pondicherry. These three distinguished moderators are going to be taking the cases presented by, to begin with, Dr. Devendra Singh Bisht, who had finished his fellowship in Mount Sinai, New York, and now he's a consultant electrophysiologist at Mukut Hospital, Chandigarh. Let's begin with Dr. Devendra. After that, we will call upon Dr. Harsh Kumar Pandey. So over to the moderators and the presenter.
Is my screen visible?
Yes, we can see the slides.
A very good evening to all the esteemed. Yes. So this is a very simple case, and that is having a well-known and controversial phenomena, that is the RF-induced upper common pathway block, and there was the associated rate-related bundle branch block that initially masquerades as ventricular tachycardia. So my case is a 64-year-old female. She has a past medical history of medically controlled hypertension, and she was suffering with palpitations for 2 years. She has a documented narrow complex tachycardia that requires multiple pharmacological cardioversions with adenosine and diltiazem, and she was taking the diltiazem and beta blockers for the same therapy. She also has a documented tachycardia cardiomyopathy that recovered at the time of presentation, and she was referred for EP study and RF. So this is the baseline EKG before that showed a normal sinus rhythm with no baseline pre-excitation. And a narrow complex tachycardia was very easily inducible during catheter placement. So I placed one decapolar catheter in the coronary sinus, one quad at the His, one quad in the right ventricle, and ablation was used as a standby if required in the HRA position. So this after terminating this tachycardia, I did a program ventricle and atrial stimulation. I first started a RV pacing that showed a concentric and decremental VA conduction with a VA Vanquivac of 300 milliseconds and VERP of 450 to 50. I didn't decrement further because this is a SVT study and I do not want to induce any ventricular arrhythmia. So this is a narrow complex tachycardia that was very easily inducible with a programmed atrial stimulation, having a tachycardia cycle length of 360 milliseconds. The tachycardia induced with a AH jump. There is a fixed 1:1 VA relationships. The His was the earliest signal, and there is a concentric activation of A and V channels. So this tachycardia was non-sustained because patient was taking various nodal blockers. So I used isopril as a medication to sustain the tachycardia, and just to do some maneuvers that confirm that this is a typical kind of slow fast AVNRT. So I used the isopril stimulation, and this isopril stimulation reduces the cycle length of tachycardia from the initial 360 to 250 milliseconds. And the RV overdrive pacing showed a VAHV response with a PPI minus TCL of more than 115 and SA minus VA of more than 85. And this is consistent with the diagnosis of typical slow fast AVNRT. And because of faster heart rate and smaller tachycardia cycle length, there is also a rate-related bundle branch block in the surface EKG. And this disappears when the tachycardia cycle length slows down. So I concluded that this is most likely the rate-related bundle branch block that is seen. So after confirming the diagnosis that this is a typical slow fast AVNRT, I decided to ablate the rightward inferior extension of the slow pathway. I used a 4 millimeter non-irrigated deflectable ablation catheter and placed at the slow pathway. During RF, to ablate the slow pathway, this phenomena happens. And this is very consistent phenomena that keeps on happening each time I was applying the radio frequency at the rightward inferior extension. So this is each time the RF application initiates the tachycardia, and there is a 2:1 VA conduction with the tachycardia during the RF stimulation. So initially it masquerades at VT because there is a broad complex tachycardia going on the surface EKG. There are more V than A, but I exclude VT because the cycle length is same as that of clinical tachycardia and surface morphology is also the same as that of clinical tachycardia. So this could not be the ventricular tachycardia. So most likely this is happening because of either it is a incidental phenomena of upper common pathway block during the slow fast AVNRT, or it could be RF induced injury to the upper common pathway that is creating this phenomena, because this phenomena was not happening before RF injury, before RF current, and this is keep on happening during the RF ablation. So this is a challenge because I may damage the fast pathway unknowingly because of this phenomena. So each time this phenomena happens, I used to take off my foot from the ablator. But even at the continuous RF, there is no injury to the fast pathway. So, so I concluded that this must be the phenomena that is happening during this RF current to the rightward inferior extension, that the AV node, there is a tachycardia going on, and because of the rate-related bundle branch block, there is a broad complex right bundle branch block pattern in the surface EKG. And because of upper common pathway block, there is a 2:1 V relationship that is seen during the tachycardia. So after knowing that this is not a another tachycardia rather than the clinical tachycardia with the known phenomena of upper common pathway block, I decided to continue with the RF application of the slow pathway. So I just changed my catheter at a different location, and finally, I got a good accelerated junctional rhythm at a slightly different location than the previous RF applications. And after modification of the slow pathway, I did again a program stimulation on the isopril stimulation. And even after the highest dose of the isopril, I was not able to induce any other tachycardia. So After slow pathway modification, I did a program stimulation to look for the injury to the fast pathway. There is no injury to the fast pathway because the AV conduction is normal, and this is the my screen is fixed. So this is the post-ablation EKG that showed there is no injury to the AV node and there is still normal conduction through the fast pathway. So this So the concept of upper common pathway and lower common pathway is still remain among the long-standing controversies of the AVNRT. The upper common pathway was perceived as a link between the fast pathway and slow pathways that is consisting of transitional cells and conducted to the atria through the transitional cell envelope. So if in this diagram, if you can see this is the fast pathway and the slow pathway, then the yellow envelope is the transitional cell.
Did we lose the connection?
Yeah, looks like it.
Yeah, so till he comes back, I think there has been some discussion on the chat box. Dr. Mohan Nair was raising some important issue. Even in his absence, I think we can continue the discussion, and I hope he returns back. Dr. Mohan Nair to take over.
Thank you, Ullas, for having me for this session. It's a pleasure to be looking at electrograms and simple SVTs. Thanks a lot once again, Ullas.
Thank you, sir.
Now, about this particular case, I really am a little amused by this caption which said masquerading as VT, because during that broad complex, there is nothing to show that this is VT and not some other form of broad complex tachycardia, because unless you have an edge, I don't know whether they had an edge, that was decreased during that broad complex, you cannot get in the, if the HV during the broad complex is the same as the HV during the narrow QRS, or it is more than the narrow QRS, then it is definitely Barnett-Brand block with AV nodal reentry going on. On the other hand, if you have an HV that is decreased as compared to the narrow QRS, then you can have nodofascicular fiber conduction or of any pre-excitation going along with bystander AVNRT, or of course VT. But you need to have an edge, and I didn't see an edge in any of those during that broad complex, surprisingly. The second is that in such a situation where you're repeatedly getting a common pathway 2 to 1, I would be very scared to ablate during tachycardia. Even otherwise, I know some people are more comfortable doing AV nodal ablation of so-called modification of slow pathway during the tachycardia. But my own protocol is to do it always during sinus rhythm and look for a VA. If there's no VA at baseline because of whatever reason, then you do an atrial pacing and do it during that. But my preferred ablation procedure is during sinus rhythm. I would be very scared to do this with that 2 to 1 going on.
Dr. Raja, would you like to say something?
First, I would like to again, I totally agree with Dr. Mohan Nair. One is if you have a wide complex tachycardia, and especially if you think it could be VT, should have reposition the His catheter to have a good His signal. And also the same again that I would have terminated tachycardia and again resumed ablation and sinus rhythm. The RF signal at that point where he showed the tachycardia with the VA block actually had a larger A than the V. So I'm not sure whether, so I wanted to actually ask him whether it was probably position 2 atrial. And also the tachycardia was fairly rapid. I don't know whether there's still residual isoprenaline in the system which was causing that. But I think overall, most likely this was AVNRT with upper common pathway block, which is uncommon. But I don't think the upper common pathway block was due to ablation. I think it was just a rate-related phenomenon. I don't know what others think.
Yeah, I agree. I think that in the discussion, I agree with Dr. Raja Selvaraj on that. Because in the discussion, he said this has not been reported before. But I think this has not been reported because the moment you get it, you stop your RF ablation. I mean, if by chance you're doing it during SVT, what we have always seen is that it can occur spontaneously. And also after a couple of RF pulses, you get the upper common pathway block. We also presented lower common pathway block. So essentially, all this and entrainment studies have shown that neither the atrial musculature nor the ventricular musculature is a part of the circuit in AVNRT. That's it. So this can be seen, but you don't do RF ablation when this is going on. So I think in a teaching course, that should be the message. If you're talking of a VT, you must have the edge, or any other differential diagnosis, you must have an edge. You must reposition and look for an edge, because the edge was wonderful during the narrow QRS. So obviously during isoprenaline and the fast tachycardia, the catheter got displaced and there was no edge during that time. When you don't have an edge, you don't talk of differential diagnosis. And the second is that I would be more comfortable. I don't know, Ullas, what is your opinion about ablating during SVT and AVNRT?
I think you always have conveyed this message that the AVNRT or a septal pathways tachycardias, I don't think we should be ablating them during the tachycardia. And especially as you were saying, in this case, where you are causing a block either upper common or lower common, you are injuring some critical component there. So I think we should stop doing that. So great points, Dr. Mohan Nair. We have Channi Sriram as your co-moderator, and I would like to know his inputs. Dr. Channi?
Thank you for inviting me. This is a wonderful session. Great teaching points, and I agree in broad points what Dr. Selvaraj and Dr. Nair had said. And I think even if you assume that this was not a nodovesicular AVRT for the reasons that was mentioned, it would have been nice to see some His refractory PVCs delivered and made sure that the atrium was not advanced. At least we would have shown that there was a nodovesicular pathway there or not. But the point, the most important point, I think, is being made that it's probably not in the best interests of the patient to consider ablation during tachycardia, especially if the patient is on isopril also at the same time. Because now, even when the patient, even if the tachycardia has stopped, we usually like to have the isopril effect wear off, so that the heart is not moving a whole lot. Because when the heart is moving so much and you're on isopril, there's so much movement going on, and your catheter is not going to be stable, and your risk for injuring the AV node is going to be on the higher side. But I want to direct this discussion towards the aspect of what do people think about the atrium being part of the circuit? And I know that there's a lot of controversy on this topic. Typically, when we talk about the lower common pathway in AVNRT, that's kind of more or less whatever tissues between the lower turnaround point and the His. We don't think His is part of the circuit. So whatever intervening tissues between the lower turnaround point and the His becomes the basis of any kind of a lower common pathway. Anatomically, it's not anything distinct. The upper common pathway, on the other hand, is a little bit more controversial because there is no anatomical study that has demonstrated it. But again, I think we should think of the upper common pathway as more of an electrophysiological construct rather than an anatomical construct. I think whatever tissue intervenes between the atrium and the upper turnaround point, that can be the basis of a upper common pathway. I know that there are people that favor this versus that. So there can be an electrophysiological basis for an upper common pathway. I think it's useful to think of it as an electrophysiological construct rather than an anatomical construct. The other thing is the lower common pathway might be more of a, sometimes when you have slow AV and RTs and those two slow fibers combine and then get to the AV node, there might be an anatomical basis for a lower common pathway in slow AV and RT. So that's there. Whether the atrium is part of the circuit or not, again, is a big controversy. I think unless my feeling on all this is that definitely we have had AV and RTs where the atrium is not part of the circuit. We have seen AV and RTs with more V's than A's, and there we have to assume that the anatomical atrium, that is ultrastructurally atrium, electrophysiologically atrium, that may not be part of the circuit. But there are certain AV and RTs where people have delivered late coupled extra stimulus somewhere in the left atrium, and they've been able to reset the tachycardia, suggesting that at least some portion of the atrium may be part of the circuit. So my feeling on all that is that in many AV and RTs, atrium may be part of the circuit, but definitely in some AV and RTs, it may not be. Again, I just want to know the feeling of the panel here.
So, Chini, I think we will have this discussion at a later time. So we exceeded.
Just one point. It's
Please.
very, very interesting, actually, because from the late Josephson's group, they did try atrial entrainment and have shown that AV and RT is entrainable from some parts of the atrium. On the one side, you have that. On the other side, you have like Dr. Raja said, you have very often seeing this tachycardia go on despite atria being dissociated or atria being blocked. So you're right. I think that's a gray zone, and we can keep on talking about it. But Ullas is the final word. We may perhaps need to go.
I think I have heard you telling once the least we know in electrophysiology is AV and RT.
That's right.
So the circuit discussion, I don't think during our lifetime it would ever be settled. So Devendra Bisht, welcome back. I can see you. You created a lot of buzz here. You probably missed the action, but everything is recorded and then you will have it. It was a great presentation according to the moderator, and there are a few learning points. Thank you, Dr. Bisht, for presenting that. So I have to make an announcement here. Before I call upon Dr. Harsh Kumar, after his presentation, we're going to take 15 minutes break. And Dr. Harsh Kumar has 15 minutes for him to wrap up his presentation, followed by 10 minutes of discussion by the moderator. So Dr. Harsh Kumar Pandey, please. He's the EP fellow from the prestigious Sri Chitra Tirunal Institute of Medical Science Technology, Trivandrum, mentored by another great electrophysiologist of the country, Narayan Nambudri. So I'm sure his case presentation is going to be throwing light on many of the nuances of the EP. So he's going to be talking on curious case of LVV tachycardia. Dr. Harsh Kumar, you may start presentation.
Thank you, sir. My voice is audible, sir.
Yes, very much.
Good evening, respected teachers. Myself, Dr. Harsh Kumar Pandey, EP Fellow from Sri Chitra Tirunal Institute for Medical Science and Technology. I will be presenting a curious case of LVV tachycardia in a case of absence anomaly. So this is a case of 8-year-old girl. 8-year-old girl who's a known case of absence anomaly. absence anomaly with recurrent palpitations documented white complex tachycardia. Elsewhere, she was needed DC versions, and she is known to have a severe tricuspid regurgitation. She was having a baseline saturation of 100%, and she was referred here for EPSRFA. So this is the ECG with she was presented with. This first ECG showing sinus rhythm, short PR interval, negative delta in the inferior leads, positive delta wave in the 1 and AVL, with a small r and deep S in the V1, V2, and V3. This is suggestive of right-sided posterior pathway. The second ECG showing sinus rhythm with short PR interval and a positive delta in the lead 1 AVL, negative delta in the lead 3, a small r deep S complex from the V1 to V2, and the transition at the level of V4. This is suggestive of right-sided posterolateral pathway. The third ECG documented outside was wide complex tachycardia, a regular wide complex tachycardia of LVB morphology, transition at the level of V5, and the relatively normal QRS axis. 1 and AVF both are positive. So with this background, she was taken up for the EPSRFA. This is the ECG taken at the EP lab. The ECG showing positive delta in the lead 1 AVL and the smaller deepest complex from the V1, V2, V3 and transition at the level of V5, consistent with the right posterolateral pathway. So this was our the initial catheter location. We have put the duodecapolar halo catheter over the tricuspid annulus, his CRD catheter, decapolar catheter into the CS, and ablation catheter into the RV. And this is the baseline HV interval. Baseline pre-excitation was present, and the HV interval was lesser, 28 milliseconds. Subsequently, while manipulating the catheter, patient developed a relatively narrow complex tachycardia. You can see here there are the two different QRS RVP morphology. The initial half there is a wider RVP morphology, and the later half there was a incomplete RVP morphology. In the first one, we can see that tachycardia cycle was 320 millisecond, and the later half the tachycardia cycle was 350 millisecond. At this point of time, we have thought the patient could have a duotomic conduction, or could be this probably because of the ray-related aberrancy. So we have further analyzed the EGM once the tachycardia settled, and we have found during the EGM, during the tachycardia 1 complete RPB, the tachycardia cycle was 300 millisecond with the concentric atrial activation pattern and the positive HV interval. And for the second tachycardia with the relatively narrow QRS incomplete RPB, we have found a similar finding. The tachycardia cycle was 300 millisecond, similar atrial activation pattern, concentric atrial activation pattern, and the positive HV interval. We have further analyzed once the tachycardia settled, and we have found the septal VA pattern in the both timing of this tachycardia was similar. B to A from the HIS was 80 millisecond with the wide RBB, and the narrow RBB also remains the similar. So most likely explanation of this tachycardia was rate-related aberrancy. We have further analyzed our the cause of wide complete RBB during this tachycardia, and we have found that with the complete RBB, there was a delayed RA-RV activation. What we have did here, we have measured the QRS interval from the surface QRS to the VEGM at the lateral tricuspid annulus. It was 68 millisecond to begin with the complete right bundle branch block, and with the incomplete right bundle branch block, the QRS surface to the VEGM at the lateral tricuspid annulus was 30 millisecond. So basically, this complete RVB at the time of this ongoing tachycardia was actually due to the AVRT with rate-related aberrancy. And during this whole tachycardia, the V2A timing at the HIS level, both at the complete RVB and the incomplete RVB, remains the same. And the LV activation time, that is the surface QRS to the VEGM at the HIS, was 30 millisecond during the complete RVB, and the incomplete RVB also remains the same. So it was basically a AVRT with rate-related aberrancy. Once the tachycardia was terminated, we did the retrograde refractory pacing. With a single extra 400, the stimulus to A was 130 millisecond. At 380, it was 126, 360, 127, and at 340, it was 129 millisecond. It is suggestive of concentric activation pattern with the non-decremental conduction. Subsequently, at 320 millisecond, the stimulus to A interval was increased, which is suggestive of a retrograde ERP of the pathway. And subsequently, at the single extra of 330, the tachycardia got induced. During this ongoing tachycardia, we have did the entrainment. We can see the entrainment response here. Post-entrainment, the post-pacing interval was 372 millisecond, and the tachycardia cycle length was 300 millisecond. The PPI minus tachycardia cycle length was less than 115, and the stimulus 2A minus V2A was also less than 85 millisecond. And the post-pacing response of VAHP response, it is consistent with the AVRT. Subsequently, we did the Zipes maneuver, and we have found that just before doing the Zipes maneuver, the A interval was 316 millisecond, and just after the delivery of his VPC, the A interval was reduced to 284 millisecond. So it advanced the next A, and subsequently A interval was 332 millisecond. So this his VPC advanced the A. The atrial actuation patterns also remains the same. So this consistent with the presence of a pathway-mediated tachycardia. Subsequently, we did the antegrade refractory pacing at single extra of 410 millisecond. The activation pattern we can see here. The lead 2 was positive, lead 3 was negative. 390 also this pre-acceleration pattern remains the same. At 370, this pre-acceleration patterns remains the same. At 350, we can observe here the pre-acceleration pattern changed. Here, the lead 2 from positive become negative, and lead 3 from negative becomes more negative. So up till 350, we have got this ERP, antegrade ERP of this right-sided posterolateral pathway. And subsequently, from 350, we have given one single more extra of 330 millisecond, and the tachycardia got stimulated. So this 330 millisecond suggests you of antegrade ERP of right-sided posterior pathway. So till now, we are dealing with the two different manifest bypass track. First is the right posterolateral pathway having antegrade ERP of 350 millisecond, and second one is the right posterior bypass track having antegrade ERP of 330 millisecond. So at this point of time, we have thought how to bring out these two different pre-excitation pattern with separately. So we did the first CS distal pacing, and we have found here that lead 2, 3, and AVF all are negative here, suggestive of right side posterior pathway. Subsequently, we did the pacing from the RA free wall, and we have found here the lead 3 becomes more negative, lead 2 becomes positive, and otherwise it is suggestive of right side posterolateral pathway. So different pacing from the different side bring out the different kind of manifestations of these pathways. And subsequently, we started mapping the the right posterior pathway under the CS distal pacing. And during the CS distal pacing, we have found that the RF distal signals was 35 milliseconds prior to the surface QRS. So at this point of time, this is our fluoro positions of the RF catheter. It was located at the 6 o'clock of the tricuspid annulus. At this point, we have delivered the radio frequency energy, and within the period of around 3 seconds, this pathway got terminated. The lead 2 from negative becomes positive here. And this is the EGM showing the good AV fusion at the beginning of the RF delivery, and at the end of RF delivery, the A and V got separated. And subsequently, there is a spontaneous reduction of tachycardia 1 with complete RBV morphology. During this ongoing tachycardia, we again map this tachycardia around the tricuspid annulus, and we have found a good VA fusion at the level of CSOS, at the lower lip of CSOS. So at the lower lip of CSOS, we have delivered the radio frequency energy, and within 2 seconds, this VA fusion we have seen at the lower baseline level in the RF distal, it is got separated. So till now, we have ablated the right posterior and the right posteroseptal pathway. We have continued the CS distal pacing, as we know that to begin with, the right posterior pathway was induced during the CS distal pacing. So we continued the CS distal pacing to assess whether the right posterior pathway is still conducting or not. So as we continued the CS distal pacing, there was a LVB tachycardia got induced. We can see on the latter half of this EGM, there was a LVB tachycardia. And surface ECG also we can analyze here. There was a LVB tachycardia. This wide complex tachycardia of LVB morphology, 1 and AVF are positive, suggestive of a normal axis, and transition at the level of B5. So we have analyzed the EGM of this white complex tachycardia. Here the HV interval was negative -60 millisecond. The AV interval was 178 millisecond and the A interval was 324 millisecond. And we have also analyzed here the RF distal catheter, which is placed more apically, get activated first, and the his bundle catheter, which is placed more basally, the V signals came late. So overall, this finding suggests there is a negative HV interval, and the AV interval is more than 50% of the A interval, and the RV apex activated first, then the RV basal. So overall, this suggests this white complex tachycardia could be an antidomic tachycardia, which is conducted through a decrementally conducting pathway. And this is, we have done the in treatment during this ongoing white complex tachycardia. During this white complex tachycardia, we have found that there's a stimulus to A minus B to A interval was less than 85, and the PPA minus tachycardia cycle length was less than 85, was less than 115. So overall, this finding suggestive of antidomic AVRT. During this ongoing white complex tachycardia, we have delivered a single ventricular extra. And what we have found here, that there is a advancement of the HH interval, and followed by there was an advancement of the A interval also. So this suggests that during this ongoing tachycardia, this VPC gone through the right bundle through the node to the atrium. So it advanced first the H and followed by atrium, which is consistent with the this pathway mediated tachycardia. And subsequently, we had delivered a late septal APC. This late septal APC has terminated the tachycardia. It does not advance H or V, but it terminated the tachycardia. So it suggests that the retrograde limb of this tachycardia is a nodal limb. Subsequently, we did the RRP, retrograde refractory pacing. At 370, stimulus to A was 156 millisecond. At 240 single extra, stimulus to A was 248. There was a decrement conduction. And subsequently, at 230 millisecond, there was a VA block. So overall, this suggestive of decremental nodal conduction and no retrograde pathway conduction. Subsequently, we did the integrate refractory pacing from the RF free wall. And we have found that at the single extra of 410, there was an increase in the AH interval was 75 millisecond. A2 delta was 41 millisecond. At 390 single extra, A2H was further increased to 92 millisecond, A2 delta further increased to 51, and at 350, it is further increased to 116 and 66 millisecond. So from decrease from 410 to 350, there was a progressively increase in the A delta and the AH interval, which is suggestive of decrementally conducting pathway. And at the 330, we have got integrate ERP of this pathway. The QRS complex in the V1 we can analyze here broader, and it become relatively narrower here. And we have got here one junctional beat. This junction beat could be because of presence of any other pathway or could be a nodal conduction. So AP finding of this third tachycardia was it is an antidomic AVRT. It was a decrementally conducting accessory pathway. There was no retrograde conduction through the accessory pathway. There was the earliest B activation at the RV apex, then the annulus. The retrograde limb of this pathway was the nodal. So all these features pose in favor of right-sided atrovesicular pathway. So we started mapping of this right-sided atrovesicular pathway. At 8 o'clock of the tricuspid annulus position, we have got the better M potentials here. And this is our catheter location. The RF catheter was positioned at the 8 o'clock of the tricuspid annulus. So here we have delivered the radiofrequency energy, and within 6 seconds, this AV got separated. We can see here, this is Mahem mediated automatic tachycardia was going on, and within 6 seconds, the A and V got separated. Subsequently, we did the Parisen pacing, and which showed the nodal response. We can see here, with the narrower QRS, the stimulus to A interval was 82 millisecond. With the wider QRS, the stimulus to A was 138 millisecond. So with the wider QRS, higher stimulus to A, and with the narrower QRS complex, the stimulus to A was narrow. So it's just a nodal response. At the end, we have given the adenosine to induce AV block, and subsequently of AV block, there was no appearance in the pre-excitation pattern. So this was the final ECG of this patient showing sinus rhythm, no pre-excitation at this ECG, and there was an incomplete RBB at the end of this RFA. So this was a case of absence anomaly with multiple accessory pathway. We have successfully ablated the right posterior pathway with manifest pre-excitation, right posterior pathway with manifest pre-excitation, and right atrial pathway. So in conclusion, the absence anomaly associated with the multiple pathways, including the higher incidence of the MAHIMs. This case highlights the importance of different EP manuals to bring out the different pathways, and characteristics of the typical and atypical pathway helps in its localization and application. Thank you.
Over to the moderators.
Yeah, as usual, brilliant presentation from the Sri Chitra team. From my point of view, it's a couple of things. For learning point, one is multiple pathway. What is the minimum criteria you require technically to consider a multiple pathway? I'm asking you this because, let me just finish. I'm asking you this, I can say this now. Several years back, maybe more than a decade back, Yash had sent a paper and I was a reviewer and I rejected the multiple pathway theory because it did not fit into all the criteria that are set. And when Ulla sent me this case, I again read up and still there are these minimum criteria set for you to say multiple pathways. So just as a learning point, what is your definition of multiple pathways?
So what the theory says that at least there should be 1 to 2 centimeter gap between two pathways
1 centimeter.
anatomically. So
anatomically,
that is what
was
they
there
should
1
be separated
centimeter?
by 1 to 2 centimeter.
So was there a 1 centimeter gap in the fluoroscopy in the pathways?
Sir.
There was. I didn't hear you.
Yes, sir. Yes, sir. Hello,
so,
sir. Yes, sir.
My understanding is, fluoroscopically at least 1 centimeter between the two pathways.
Yes, sir.
Second is more sure when you have the second pathway manifesting after ablation of the first pathway and not when there is a simultaneous. And secondly, I think that rate-related right bundle branch block, which is different, doesn't go, I mean, it's not a part of the multiple pathway theory.
Yes.
The second learning point where I would like to go back because it's very important and you've shown it fairly nicely, but again, to convince me, is para-Hessian pacing.
Yes.
Can you go back to that slide?
Yes. This one, sir.
Yeah. So you said that an increase in VA interval between his capture or the conduction system capture and the para-Hessian capture means that there is no retrograde conduction through an accessory pathway, right?
Yes, sir.
Is that more important or showing that the VA is, this is a negative response? To me, it could mean nothing. What is more important would have been if you had seen an HV which was same or less during the para-Hessian and his pacing. I would ask Raja Selvaraj or Ulas to comment on that. A positive response is more definitive rather than a response where you might not have captured the or not engaged the pathway during the white QRS.
Mohan?
Yeah.
Can I make a comment?
Yeah, surely.
Dr. Yash, yeah.
Yeah, actually this, Professor Jackman actually brought us on into this para-Hessian pacing, and we also do it quite a lot. But I agree with Mohan. In para-Hessian pacing, what you see is there. What you don't see, you can't say anything about.
Yeah,
so
precisely.
From here, I can say there is AV nodal conduction. I cannot rule out there could be a sluggish pathway even a paraseptally located pathway, but the AV node engages much better. So
Exactly.
what it shows, it reveals. What it doesn't show, it doesn't exclude.
Yeah. So what is your comment from this presenter?
So with this response, it is showing that it's a nodal conduction. The stimulus to it should be similar if it is a pathway mediated. But yes, if it is a slowly conducting pathway, then it is still, this conduction time could be like a nodal response. Like here we are presenting as a nodal response. So if it is a slowly conducting pathway retrograded, then also we can get this response. But
yeah, so this does not exclude you're not having engaged the pathway. I mean,
yes,
just as a teaching.
Yes.
So it's a wonderful slide. It's a great maneuver. But as Yash said, and as I was saying, what you have seen, you have seen. You cannot comment on what you have not seen.
Dr.
Mohan,
Mohan,
can I
Dr.
can I
Mohan,
make a point?
one second. Dr. Mohan, I was about to ask you this. Does this at least say that at the site of the pacing, there's no pathway?
At the site and at the cycle length that you have paced, and at the voltage that you have paced, you have not engaged in accessory pathway.
Yeah, so that also doesn't still rule out. That's exactly. So definitely if
so
you're away from the, yeah, that's correct. I mean, how beautifully you said that. But I think Yash's, the poetic explanation of what you see is not the truth. Maybe certain things are hidden there. Great. I think Nitish was also trying to make a comment here.
So yeah, I mean, I think you are all making the good point, but I want people and the fellows especially to understand parahisian pacing is only for septal pathways. Okay,
Right.
you are showing a right posterior pathway, right? Or if you show me a left lateral pathway, you will get the same response in parahisian pacing.
Precisely.
I can show you a robust left lateral pathway where parahisian will give you the same response. So you have to know why you're doing. And if you want to show this, show it before ablation and after ablation. And I agree with Mohan. This could be, I think you have two pathways. You have atrovesicular for sure, and I won't call it Maheim. Okay, Maheim is a separate definition. But the second pathway that you're showing, the posterior versus posterior lateral, that could be a slanted pathway. I mean, the change that you showed looked antegradally very similar. When you went from little wide to more wide. And if you have a slanted pathway over there, you can show that. I mean, the antegrade and retrograde conduction can be a little bit off.
Yeah, I agree. That's why I wanted that point to be clarified. There are some minimum criteria. You're very sure when the pathways are on two sides of the septum. You're very sure when one pathway you've ablated, and after that you first start seeing another pathway. You're very sure when fluoroscopal Kili is more than 2 centimeters, but the minimum is 1. So I agree that, splayed pathway there could have this kind of response, especially in Epstein. I would be very, very defensive in saying there are multiple pathways that have been shown.
Thank you, moderators. Anybody is commenting?
I mean, for the sake of time, do we have time or no?
1 minute for you, please, Chenny.
Okay, no. Is there also any minimum criteria based on the antegrade refractory periods for the pathways? That if it's 10, 20 milliseconds here and there, does that, and if the pathways are close enough and you have a difference of 10 or 20 milliseconds in effective refractory period when you go from one slightly different morphology to another morphology, does that prove that there are two pathways, or would you still say that, yes, it could be part of the same pathway?
So any response, Mona?
Yeah, again, having been a reviewer for a case report sent from Yash, who's my very close friend, and having had the guts to actually reject, I don't think this point is being given in any of the review of literature on multiple pathways. So, which means that you could have, depending on from where you're pacing, a so-called ARP, which is a few milliseconds here and there. I could be wrong. I might have missed some multiple pathway, reports. But this is not one of those criteria laid down.
Yeah, I agree with you, Mohan. I think it's this millisecond. I think mostly I see happens is people miss a slanted pathway, and they will ablate one, and then they'll say, "Oh, I found another one which is right there, but it was slanted." The last point I want to make, which was very nicely shown in this presentation, is if you ablate the antegrade pathway and you continue to have left bundle branch block in a patient with Epstein's anomaly, you know there is another pathway present, because in the end you have to have right bundle branch block. So in sinus rhythm in a patient with Epstein's, if you don't get right bundle branch block, you have to find the other pathways.
Very well said, Dr. Nitish. Absolutely great. Dr. Mohan Nair, you know what, I think all of us, definitely the attendees, have learned so very much. And I think all our gray matter require little rest. So thank you, the moderators, the presenters. We have heard 4 presenters. Thank you all. Now, let's take a break for 15 minutes. And we come back by 7 p.m. I wish everyone will join back. Thank you.
Thank you, Olas. I will not be able to join back because I'm in another meeting.
All right, but your inputs and your critical analysis of
I'll try to come back as much as possible. Yeah. But yeah, I'm in a hotel room in a convention center. So.
It had been a privilege. I'm sure all the attendees have learned so very much, about your critical analysis and the nuances of EP. It is no other person I think could deliver as much as you. I remain grateful. Thank you so very much. Thank you so much.
God bless you.
Thank you.
Pacing system. The ARIA lead was Medtronic 5076, and the RV lead was Medtronic 3830. You can see the results. The LVAT was 72 milliseconds. The QR at first was more dominant, and then it diminished. And the QRS duration was suboptimal at 150 milliseconds. As we try several locations, and this was the best approach, and given that her LVF was normal, we decided to continue and to take these results. You can see her ECG on the lower right aspect of the slide, and the post-op X-ray on the right top side. So I was called to see her 36 hours post-op because of this finding on telemetry. Here, as you can see, it was on June 1st, 2022, on 2:07 a.m. So we can see here that it was the pacemaker function as a sense V pace, and there's a P wave, which is not followed by QRS, and it seems like a dropped QRS complex without ventricular pacing. I went back to the patient to see her. We repeated the X-ray. You can see here the X-ray. The electrode looks well without any movement or change from previous X-ray. The patient was asymptomatic. It happened during the night. She slept through, but she felt nothing. And device interrogation revealed normal and satisfactory parameters. They were identical to the parameters that we had post-op, and also there were no alerts on the pacemaker. So it was interesting to open up a debate now to see what's your thought. But we consulted our colleagues, including Medtronic engineer, and we found out 2 case reports that can supply us with an answer as to what happened with this drop QRS complex. The first one was in 2015, an EP case report from a group at the States, and another one from a group at Toronto General in 2018, published in Heart Rhythm. So both of these case reports and our experts' opinion think that the tracing can be explained by the reference EGM collection feature that Advisa pacemaker has. So this is a non-programmable feature in the Advisa MRI pacemakers. This feature occurs every 1 hour, and it takes time for the feature to act. So there is an additional 30 seconds to each time it happens. And what's happening every 1 hour, as I said, in 30 seconds, is that there's a collection of the EGM for reference. It's available on the remote system, and as the pacemaker collects the EGM, there is an amplifier for the EGM. And the turning on and off of this amplifier feature can cause residual noise that can inhibit the V-pace. Now, typically we see this phenomenon in patients with complete heart block and dual chamber mode because of the Asense V-pace mode. The issue is that the pacemaker needs to not have the post-atrial ventricular blanking period, so that it won't blank the noise that is being caused by this feature. And the worldwide rate of occurrence, as being reported according to Medtronic engineer, is below 0.5% of the Advisa pacemakers implanted. We scheduled her for a 14-day halter from July 12th to the 25th. And you can see here that out of the entire electrical activity, 0.03% of the activity included blocks or pauses. And you can see here 2 examples from these tracings, including same as we saw on the telemetry. We can see here a P wave, which is not being followed by a QRS complex, and what looks like a dropped QRS complex. So how can we recognize this phenomenon? First, it happens almost exclusively. It can happen with different Medtronic pacemaker. It happens almost exclusively with the dual chamber Advisa pacemaker, and specifically with an Asense V-pace with the tracking pacing mode. This phenomenon is occasional, happening every 1 hour and 30 seconds between each time happening. And a solution that is being offered, and we're going to bring back the patient to our device clinic and to try to see if we can eliminate, even though she's asymptomatic, is by decreasing the sensitivity. Now where sensitivity is 0.9, to decrease sensitivity to 1.2 millivolts or higher, and this may eliminate the phenomenon, as the noise will not be sensed. So I just want to go back to the patient just to prove that indeed this can explain the phenomenon we saw, the tracing we saw in this patient. So when I saw the patient, I went back to telemetry and I screened the 48 hours post-op, and I could find only 2 episodes of dropped P wave, of dropped QRS. And you can see here these 2 episodes, and the time between the 2 episodes here, this is the second episode is exactly 1 hour and 28, almost 30 seconds. So I think it settled the case, and that's it for today. If you have any questions or comments, that's my email below. Thank you so much for participating.
Oh, excellent. So over to the moderators.
Oh, very nice presentation. I learned something new every day. We have implanted a lot of Advisas, but I've never seen this. So thanks for bringing this to this forum. And Dr. Pandurangi, congratulations on such a wonderful conference. Since this is a EP fellow teaching course, I was hoping you can go back to your slides so we can make a few points. Would you be able to share it again?
Sure.
And perhaps go back to the very first telemetry slide that you had. So this is a common thing that fellows are going to get called for, right? So the nursing staff call because either the pacing rate is too slow for what the pacemaker is set at, or suddenly there is no QRS complex, and you're going to be troubleshooting this at nighttime, right? So when you see this, you see a P wave, you see a QRS pretty consistently, and then there's suddenly a dropped QRS. So the 2 things two broad things to think about when we see this is one, is there a pacing spike or not? So if there is a pacing spike, then you're going to be thinking about loss of capture, right? So it's a slightly different issue. Here you see a pacing spike when there's a QRS, but none when there is no QRS. So there is loss of output. So those two things are kind of the first things to distinguish when you find that there is no QRS where there is supposed to be one. So now you're dealing with not loss of capture, but loss of output. And I think you kind of touched upon the differential diagnosis in your next slide when you were thinking about, I'm going to get a chest X-ray, make sure these leads are still in position. I'm going to check the device, make sure the threshold is still good. And once you have done all that and you still kind of confirm that there is loss of output, that's when you start thinking about some of these more unusual phenomena. So what are the differential diagnoses for loss of output, Dr. Dadon? What kind of went through your mind when you were looking at this? Obviously, the solution from the engineers is a very unique one, right? But I'm sure you thought about more common ones before you got there.
Yeah, I think Dr. Ziv is around. She's probably asking you why there is no spike.
Yeah, so why there's
the causes of no spike, yeah.
Yeah, so why there's no loss of no spike. So most common is that there's an over sensing of whatever noise. It can be externalized, it can be internalized, it can be electrode issues, but the most common reason is for an over sensing of the underlying, any underlying rhythm. It can be local muscle, it can be external to the body, and it can be an hardware problem.
Perfect, perfect. That's the first thing you're going to be thinking about. And rarely you can find that there is failure of generators, so some kind of issue with the generator itself that leads to loss of output. So those are the two top things you should be thinking about. Very good. It's indeed a very unique algorithm that you're talking about. So when you spoke with the engineer, did they say this is far field somehow atrial activation that is getting sensed because the amplifiers are opened up? Or is the amplifier opening up kind of creating some noise within the ventricular lead itself?
So what I was told is that, again, it's a very rare phenomenon. I went back to our patients, and since 2017, the way I was able to find only two cases, one in 2017 and one, the current case, like 2.5 months ago. So I spoke with the engineers, and they told me that the feature, like the switching on and off of the algorithm, resulting with a small burst of potential that can be interpreted or can cause noise. But it's the
So
issue
it's
is that
actually-
the switching on and off.
So it is actually ventricular noise because it's opening up the amplifiers. So that's probably why the sensitivity adjustment could be a potential fix for it, provided you have large enough R waves. That sounds good. And you said the patient is dependent anyways, right?
Yeah, the patient is dependent. She's asymptomatic. It happens again very, very infrequently, 0.03% of the entire ventricular activity. But we'll try.
I think we still need to take this seriously though, because we are creating some long short coupling intervals with these events. So it still is important, just as you have planned to try to fix this problem. Dr. Nambudri, I'll turn it over to you.
Yeah, if he's not around, yes, Dr. Malini, I just was thinking about the same thing, apart from the engineering limitations here, that it seems they cannot overcome this because of certain engineering issues. But this is potentially a serious issue for all of us, especially when you have this short, long kind of event going on every 1 hour. And if you have some electrolyte imbalance or a structural heart disease, it is like calling for trouble. I remember when the Medtronic introduced for the first time minimizing the ventricular pacing, they needed to go back and then work upon, and then they had to change that MVP mode to the one which is a safer MVP mode. I really agree, Dr. Malini. I hope we need to be, bringing out a solution for. This should not happen.
I think somebody had asked in the chat if this could be MVP. I
Exactly.
believe MVP was turned off. This was a DDDR pacing mode.
So I think that's a great question. It is from my colleague, Dr. Anindya Ghosh. I think he had done more number of advisor MRI, than me. And then most of his devices are all remote monitored. I hope Anindya will dig into those data. And I don't know how do we get that, because that cannot be a part of an alert from the remote, but we sort it out. Anindya, if you can unmute and then speak a few words about that, you are welcome.
Good evening, sir. Actually, SSKR had asked that question, but there have been issues with Medtronic pacemakers where we thought could be ventricular oversensing, but that has mostly been with conduction system pacing, and we personally haven't encountered anything of this sort as of now.
All right. Okay. So
one. Can I make
please
one
go ahead.
point?
Whoever is speaking, please go ahead. Whoever is speaking.
It's Dr. Sriram. Hi. With MVP mode, after you lose one capture, the next duration of the A-sense to V-pace should be shorter.
Shorter, yes.
It's 80 milliseconds. It's fixed and
Yeah.
programmable. The first beat comes after that is 80 milliseconds. Here it is.
Absolutely. Absolutely.
So otherwise, this is one way to differentiate from it.
Narayanan, your mic, please adjust, please.
Yeah. In the MVP mode, the first is 80 milliseconds. Here it is essentially same in all the bits.
Yes,
That is
I
how we
agree.
can differentiate from
So that's not the part of it.
Can I see the X-ray? Can you just show the chest X-ray? Here, if you see the lateral view, the RV lead appears anteriorly placed.
Yes, Narayanan, they agreed upon, actually they could not achieve a good, so-called narrowing of the QRS. They have already agreed upon.
Connection system.
Yeah, so it does not really.
So the underlying structure of heart disease is fine.
Dr. Malini, I think Narayan Nambudiri's voice is breaking. You have any more comments to make, Narayan?
No, nothing.
Okay. Dr. Malini, don't you think it's actually a great case? And well, that's what, engineering technology has helped us to take care of our patients, but there are definitely some serious limitations. And that this, I think, should be quickly fixed. What do you say, Dr. Malini? This is because of an engineering issue. I do not think we should be, doing a lot of such cases, especially if the patient is predisposed to ventricular arrhythmias. What do you say, Dr. Malini?
Yes, I agree. Definitely. It looks like they already have a plan to bring her back and address this. I think the sensitivity settings will probably help with this. Particularly, the sensitivity is not that important if the patient is dependent. You still want the ability to sense things like PVCs, but that would probably be the best first step. If it doesn't fix it, then sometimes you could go back in and put a new generator in, which doesn't have the same programming issues. That would be the last resort.
But I think I think my colleague Dr. Anindya will agree with me that Medtronic had not actually emphasized on this particular part that we could actually overcome with adjusting the sensitivity. Anyway, we'll discuss about it a little later more in our clinical.
Can you hear me?
Sir, absolutely, we hear you.
I wanted to ask a question to those who have experience with AV sequential micra. Probably our colleagues from the US have more experience.
Yes.
Are they encountering more pacemaker issues or troubleshooting issues with the AV sequential micra than with the standard dual chamber pacemaker?
So Dr. Lokhandwala, I think we have done a lot of AV sequential micras. I think the major issue with that is it's not perfect synchrony. You cannot expect anywhere close to perfect AV synchrony with the AV micra. the best we can get. The company claims, 80%, but that's kind of an ideal situation. A lot of our patients end up with a lot less AV synchrony than that 80% that the company claims. I think that's one major concern with that device. The second major concern is beyond a heart rate of 100 to 110, because of some of the blanking periods within the device, there's just no way you can ensure AV synchrony with that device. So it's okay for very elderly patients who you don't expect to be very active, and who you don't expect to have issues with AV dysynchrony. But if you want perfect AV synchrony, it's really not the ideal device for that. In fact, there have been a few patients where we have put in the AV synchronous Micra, and then we end up using it as a VVI pacemaker because there's just no way we can troubleshoot to make it synchronize. That's rare. That's not a common occurrence, but those are all things to kind of keep in mind when thinking about the device.
A great points, Dr. Malini. Should we call upon the next presenter? And he is the fellow being mentored by Dr. Yash Lokhandwala. That particular case, I'm sure it's going to be as interesting or more interesting than the previous ones. So it's my privilege to call upon Dr. Surampalli Vijay, who is the fellow, lucky fellow, getting mentored by none other than arguably the most knowledgeable electrophysiologist of our country, Dr. Yash. Surampalli Vijay is going to be presenting recurrences of tachycardia after repeated slow pathway ablation. I'm glad that this is being moderated by Malini Narayanan, and the mentor himself, Dr. Yash, is also around. Let's learn from S. Vijay.
Yes, sir. Good evening, sir. Sorry, are my slides visible?
Yes, very much.
Yeah, thank you, sir. Thank you so much. And I would like to thank you, Ullas sir, and my mentor, Yash Lokhandwala sir, for giving this good opportunity to present my case here. So coming to my case, the case is like recurrences of tachycardia after repeated slow pathway ablation. Coming to the case details, my patient is a 30-year-old man presented with recurrent episodes of rapid paroxysmal palpitations for about 2 years, and out of which few were terminated with the verapamil, and echo was normal. So patient has been has been diagnosed as a typical AVNRT, and he underwent about RFA of slow pathway twice in an year. However, the episodes were recurred. So patient was taken for electrophysiological study, and the narrow complex tachycardia was easily induced with the RBBB monomorphic R wave RBB morphology with indeterminate axis. The rate ranging from around 170 to 180 was easily inducible with the programmed atrial and ventricular extra stimuli. And if you see the electrogram here, which showed A and B tachycardia with AH of around 42 milliseconds and HA of 42 milliseconds and AH was 30 milliseconds. So looks like a typical AVNRT, maybe the reason why patient underwent a slow pathway ablation twice. So the differential diagnosis for this A and B tachycardia are most commonly typical AVNRT, atrial tachycardia, and nodovascular or nodoventricular orthodromic AVRT. So during the tachycardia, we did a ventricular rotary pacing. With the tachycardia was entrained in third beat, and post-ventricular rotary pacing, if you see, there is an VAB response, which rules out atrial tachycardia, and at the same time, during spontaneously there was a during the tachycardia there is a 2-to-1 intermittently there is a 2-to-1 VA conduction, which also rules out the atrial tachycardia. And next we did an is-refractory VPC to rule out nodovascular or nodoventricular mediated tachycardia, orthodromic tachycardia, but the is-refractory VPC did not affect the tachycardia, did not affect the next EA, which also reasonably rules out the nodovascular or nodoventricular mediated orthodromic AVRT. So if you see the tachycardia initiation properly, so the tachycardia was initiated with the 2 atrial extra stimulus here. So with atrial to atrial extra stimuli with an AHHA initiation. So this AHHA initiation, the differentials will be either typical AVNRT initiating with the double fire phenomena, that is 2 for 1 phenomena, or it has to be ventricular tachycardia involving the fascicles, as it is easily induced with the atrial extra stimuli also. So to confirm this, so if you see, we interrogated the electrograms again during the tachycardia. So if you see the HV interval during the tachycardia, it was around only 34 milliseconds when compared with the HV interval during the sinus rhythm, so 54 milliseconds. So this rules out SVT with aberrancy, unlikely this AVNRT with RBB aberrancy. But because in case of SVT with aberrancy, the HV interval either it should be similar to the tachycardia or it should be more. And we confirmed it by giving the adenosine. So adenosine caused the retrograde VA block with the continuation of the tachycardia. So which confirms that it is ventricular tachycardia, not the AVNRT. So to confirm the diagnosis, finally, we did an atrial overdrive pacing during the tachycardia. So which showed an interesting finding that here in the red arrow suggests during the tachycardia, we gave an atrial overdrive pacing. And the red arrow showed, left figure red arrow showed there is an QRS became suddenly narrowed down. So with the atrial overdrive pacing, the QRS became narrowed down, almost similar to the sinus rhythm, and with the star showing a fusion beat. That is, tachycardia was entrained with a manifest fusion, which indicating that the tachycardia is a mechanism likely due to the re-entry mechanism. And at the same time, the tachycardia, the QRS narrowed down during the atrial overdrive pacing, again further ruling out the bundle branch aberrancy, SVT is the bundle branch aberrancy. So the diagnosis was confirmed that it likely due to upper fascicular VT involving the fascicles, and we mapped the mapped during the tachycardia, where we can see the fascicular signals are earliest preceded the QRS by around 45 milliseconds in the upper septum. Both in RA and LO, it showed that just below in the upper septum, just below the bundle of his. So it is almost nearer to the AV node and bundle of his. So after discussing this precarious situation with the patient relative attendants, and so few energies were attempted during the sinus rhythm. With the second energy during the tachycardia was terminated. And after that, few energies were given during the sinus rhythm also. So after that, there was no tachycardia was inducible. And in a 6 months follow-up, till now, there were no recurrences to the patient. So this was the rare variant of upper fascicular VT, which was successfully treated. So if you see the review literature, actually the upper septal fascicular VT was very rare entity when compared with among all the idiopathic left ventricular VT. So in a study by Hamed et al. In their findings are published in JACC Journal 2015, in which around 193 patients of file VT, only 12 patients were identified as upper septal VT. With a QRS of, in all the 12 patients, the mean QRS was around 104 milliseconds. So it is almost looking like a narrow QRS tachycardia, which can mimic, most likely mimic the AVNRT, unless you were very careful. And in all the patients, the mean HV interval is around 27 milliseconds. When compared with the sinus, HV interval is around 47 milliseconds. So finding the HV interval during the tachycardia, comparing with the sinus rhythm, helps in suspecting this upper fascicular VT. And even though the exact mechanism was not known, so in their study they proposed the one hypothesis that, and they found the diastolic signals in and pre-systolic signals were almost opposite to the common idiopathic left ventricular tachycardia. So in usual left idiopathic left post-fascicular VT, the P1 indicates diastolic signals which are earliest seen in from the distal to the proximal to the distal, the catheter in the LV side of the septum. So if you see in the middle common idiopathic left ventricular VT, the P1 signals, that is earliest signals in the basal part of the catheter, basal from base to the apex. So if you see in the upper septal fascicular VT, it is in the reverse direction. That means they hypothesized an mechanism that in case of common idiopathic left ventricular tachycardia, the antegrade conduction is through the that is P1 through the slow pathway and retrograde conduction through the left posterior fascicle, which is reverse in case of upper septal idiopathic left ventricular tachycardia. That means the retrograde conduction, that is P1, and antegrade conduction is through the both posterior fascicle and anterofascicle simultaneously. And his was activated retrogradely. That's why the HV interval is actually pseudo interval, which is shorter than the sinus rhythm. So all turning points are all A and B on B tachycardias are not AV and that's where the measuring the HV interval during the tachycardia and comparing with the sinus rhythm can easily rules out AV and we can diagnose the upper septal fascicular VT, which can be confirmed by the atrial overdrive pacing and adenosine administration. So upper septal fascicular VT can mimic AV and many case reports were there where patient has been underwent slow pathway ablation, which can be very dangerous also by damaging the AV node. Thank you, sir.
Thank you. And over to the moderators.
This is fantastic, just simply fantastic. So congrats to both the fellow and his mentor. Beautiful case, all beautifully made teaching points as well. I know I agree with all the interpretation. Since again, this is a teaching conference for the fellows, I would like you to maybe just take a minute to talk about this HV interval that you mentioned, being a pseudo interval, and hence being short during tachycardia versus sinus rhythm. So tell us a bit more about it. So all the fellows going home from here will keep that imprinted in their mind. This has already come up once during one of the other cases. So give us a little bit of explanation for why that's a pseudo interval and why that's short during this tachycardia.
Yes, ma'am. So here in this diagram, we can clearly see that the mechanism of tachycardia. So actually what is happening is like in any VT, suppose in case of common idiopathic left ventricular tachycardia, see here the antegrade conduction is through the slowly conducting calcium sensitive slowly conducting zone, which is called P1 signals, and retrogradely it is conducting to the left posterior fascicle retrogradely. At the same time, it go antegradely to into the myocardium to stimulate the heart. So that's where the QRS will come. So just before this QRS come, the conduction will go retrogradely through the left posterior fascicle and retrogradely into the his. So actually his is activating retrogradely just before stimulating the heart, myocardium. So that's why actually the HV interval is a pseudo interval. It is not antegradely conducted H. It is conducting retrogradely from the myocardium. That's
Very
why it's
good.
called
So
pseudo HV interval.
Perfect. It's a pseudo interval because there is simultaneous activation towards the His, and at the same time, the ventricle is also getting activated. So that H to V interval is going to look short. But if you have sinus rhythm, it has to be a true interval. The conduction has to go down the His Purkinje, and then create a V, so that H to V is a real interval, and it's going to look long. Perfect. So tell us a little bit more about how you map this tachycardia. I'll give you a few choices. Did you map the earliest V? Did you map the earliest His? Or rather, did you map the earliest Purkinje system potential? Did you look for a P1, P2 potential like the paper that you just showed? Or did you use entrainment because it sounds like you had sustained tachycardia? Tell us about all the different techniques that you used and what you think is most useful in these fascicular type tachycardias.
So, ma'am, here we use the Purkinje fascicular signals only, ma'am. In the 2D mapping, we checked for the earliest fascicular signal during the tachycardia. It is around 45 milliseconds preceded the QRS complex. That's where in the upper septum.
Great. Very good. So there are many ways of mapping VTs, right? But there is some of the usually used techniques for mapping myocardial VTs are not helpful in patients who have fascicular VT. So for sure, mapping the earliest V is going to get us nothing because it just gives us where the VT exits into the myocardium. And in the case of fascicular VT, that's likely to be multiple spots. So it really doesn't give us much. So that should be entirely out of the picture. We should never map the earliest V, except for maybe if you're trying to figure out where this is exiting.
Yes, ma'am.
Mapping the earliest fascicular signal can be helpful, but it is not the whole story, because we have to keep in mind that a lot of these fascicular VTs are not automatic. They are re-entrant in mechanism, as is, as you showed using those papers. In fact, when we look at your own signals here, the first panel that you have here on the left-hand side, there are actually two signals ahead of the local myocardial signals on that catheter that's labeled RFD. So there is a slightly far field looking signal. If you want to point out to that, perfect, yes. And then a little more near field looking Purkinje type signal. And then you have the local ventricular signal, right?
Yes.
So that probably represents part of your reentrant circuit. Usually that first signal represents the slow zone, and hence it is not as near field, not as sharp as a Purkinje signal. And then the second one represents your P2, which is your Purkinje signal. So that's one reason why mapping just the earliest Purkinje signal alone is okay to do, but it doesn't give you the whole story when you're mapping a fascicular VT. You should be looking for both of these types of signals, the P1 and the P2. That can be done either with just a roving mapping catheter like you did, or it can be done by putting a multipolar catheter in that area. That's very good. How about the role of entrainment? What do you think about the role of entrainment in fascicular VT?
Sorry, ma'am, I'm not sure.
Did you attempt entrainment in this case?
Yeah, by atrial aortic pacing, we did that entrainment, ma'am. Yeah.
Okay.
But not
I think
during the mapping.
that is a little bit hard to know. It could have been entrainment from the atrium. I would just take it with a pinch of salt because you were easily inducing the tachycardia from the atrium, right? So sometimes when you pace overdrive pace from the atrium, you could terminate and re-induce the tachycardia. So as long as that is not happening, that could be entrainment from the atrium. When we think about entrainment from the ventricle, it's just important to keep in mind that in this situation, we can't use the usual parameters we use to look for entrainment of the circuit. So when we pace the tachycardia during a fascicular VT, there is a chance that you would capture the fascicle. There's also a chance that you would capture the local myocardium, right? So the only way to show that you have concealed entrainment is to be able to capture the fascicle and have a multipolar catheter in that area to show entrainment of the fascicular signals themselves. So the usual way you look at entrainment is to look at the 12-lead QRS morphology, see if it is entrained or not. Is it concealed? Is it fused? But in a fascicular VT, that's not going to work because you will be capturing local myocardium as well. And the QRS, for that reason, but also for reason the exit can vary from beat to beat of pacing, is going to look different. You're not going to get a perfect looking QRS entrainment on the surface. So using those usual criteria for entrainment will not be helpful. So you need to have a multipolar catheter within the fascicular system and show that the fascicles themselves are entrained. And you can compare if you have a multipolar catheter activation sequence during the pacing versus during tachycardia. So that can be that can be difficult to accomplish. So entrainment can be helpful, but it can be very difficult to prove. The other thing when you entrain is to look at, when you look at the PPI and compare it to the TCL, you should be looking at the PPI as it is with the fascicular signals, not with the myocardial signals. So you should be comparing the PPI and TCL of the fascicular signals instead of the myocardial signals. But I do think in majority of cases, what you did would be entirely appropriate. Map the earliest fascicular signal, but also keep looking for these P1, P2 signals to really assess where this reentrant circuit is. I think something as proximal as this, it's really, some risk for either a left bundle or AV block. So just being careful with these upper septal fascicular VTs during ablation is important, especially in such a young person. I believe your patient was quite young, right?
Yes, 30 years.
Yeah.
Can I ask a couple of questions?
Yeah, before that, Ullas, I would like to ask Malini a question because, to be frank, Malini, we did not attempt entrainment because I was not very familiar with how to interpret it, and generally I would expect another arterial puncture and another decapolar catheter. I did try that in the past, and sometimes it's stable, sometimes not. Here, of course, I didn't have the worry that VT will not reinduce. Sometimes you have the worry that it will terminate. Here, it was very easily inducible, but really, what point you said is very good. Only thing I'm not familiar with how to interpret it. So maybe if you could send us, not right now, but later on, some literature, we can go through it as to how to exactly do this entrainment and look at the potentials. That would be useful for all of us.
Absolutely. Actually, one of my colleagues, Dr. Suraj Kapa, wrote a very nice review, and I think he had some of these concepts explained with the examples of tracings as well. So I'll be happy to share that. That may be easier to share than finding cases. I'll send it to Dr. Pandurangi, and maybe his team can share it.
Absolutely, great learning. I just was wondering, Dr. Yash, Malini was bringing up that the P1 potential. Were you looking at that, or you did not really look at that P1 potential while you were ablating?
No, to be frank, Ullas, when I saw these two potentials, both early, one earlier than the other, then I thought that this will be probably close to the turnaround point in the circuit, and safety was more on my mind. And then I saw the two potentials. I said, we're near the turnaround point, and this looks good to go. But I did not do any entrainment, I must confess.
You know what, actually, Surampalli did very, very well. I think among the juniors who was trying to explain to us about the circuits of these idiopathic left ventricular tachycardias, I think that was the best way, he presented according to me. Congratulations, Surampalli, and that is why you are the winner of the EP Fellow Summit Award. So thank you so very much. I think it was absolutely a great first part of this, the final session. Now let's go to the second set of presenters.
Can I make up?
Oh, yes. Nitish,
can you? Yeah. I just want to make one more point. Can you go back and show the differential when you showed initiation with AHHA? Go back to the slide where you show initiation with AHHA.
Yes, sir.
Yeah. So before you put number 2, the two differentials, then when you get an initiation with AHHA is actually AVNRT and junctional tachycardia. AVNRT with double fire, which is less common, but junctional tachycardia is more common. And then the third is VT. And I think you're right that HV short will not happen, but in junctional tachycardia, sometimes the focus can come from a different area than the perinodal tissue. It can be lower down. So the HV can be shorter in junctional tachycardia. It's usually similar to that, but it depends on where the junctional focus is coming. So that's important to remember. And also when you do overdrive pacing of fascicular VT, you can get an AHA response. In this case, you would not, because you showed when you were doing atrial overdrive pacing, you showed that the QRS morphology changed, right?
Yes.
So there you would have gotten AHHA, but you can get AHA if you're just going through the conduction system, right? There it will look exactly like the morphology of VT. So to me, that could also something that could argue for focal versus reentrant in terms of etiology of the fascicular tachycardia, because they're not all reentrant.
Yeah, but Nitish, when the junctional focus comes from little lower zone, that becomes the VT as well, right?
Well, you get it from the right side. You don't have to go to it looks more like the intrinsic, but it would not be. Yeah, I mean, you can semantically say it's lower in the conduction system, but
But what's more important to me,
About
Dr.
an intra-His type of tachycardia, and I agree, it's kind of a terminology debate. We can debate all day about.
Yeah. But Dr. Malini, what is more important for me is Dr. Nitish is still around, and his inputs are always welcome. Nitish, hang around. We are going to get into the second set of the presenters. Again, going to be moderated by one of the best of the electrophysiologists whom I respect most. One is Dr. Abhishek Deshmukh. He had been a mentor to all of my fellows all the time, from the overseas, online. Dr. Anindya, Dr. Anand, and many of the fellows across the country, they attend to his classes. So maybe whoever is interested to be attending to Dr. Abhishek Deshmukh's online classes can contact us. So we have him here, and he is a cardiac electrophysiologist again from Mayo Clinic, Rochester. Accompanied by him is our respected electrophysiologist of the country, Dr. Anil Saxena, very distinguished personality. He had been the past president of the IHRS, and today he's with us. He is the director of cardiac pacing and electrophysiology of Fortis Escorts Heart Institute, the prestigious institute. These both, the Dr. Abhishek and Anil Saxena, would be moderating two presentations to begin with. Is a fellow from JIPMER Pondicherry. I told you the JIPMER Pondicherry is Jawaharlal Institute of Postgraduate Medical Education Research, where our friend Dr. Raja Selvaraj is mentoring several fellows there. One of them is Dr. Dinakar Butla. Welcome, Dr. Dinakar Butla. So your topic is for discussion now. Share the slides, please.
Can you see my slides?
Yes. Yes.
Good evening, everybody. I would like to thank Professor Ullas Pondicherry and Professor Raja Selvaraj. Now I'm Dr. Dinakar Butla. I'm doing my EP fellowship in JIPMER. I'm going to present one of our case, which is a narrow QRS tachycardia before you ablate. So. She's a 7-year-old child. She presented to our outpatient department with history of recurrent palpitations from last 6 months. So the 12-lead ECG that we have at that point, we can see that there is a short PR interval and there is subtle pre-excitation. The pre-excitation that we see is more clear on the lateral precordial leads with a positive delta that we can see from V4 to V6. And the delta wave is isoelectric in lead V1. Also in the lead 3 and AVF, it is not very much pre-excited, but the lead 2 shows a positive delta. So we were thinking more like a mid-septal axillary pathway at that point of time. And so she had one episode of documented tachycardia, which was adenosine responsive. So that tachycardia was a regular narrow QRS tachycardia with heart rate was around 190 beats per minute. We can notice from here that the QRS, although appears narrow, there is a slight slurring of the initial part of the QRS complex in the lateral precordial leads again. And there are ST depressions in the lateral precordial leads with also in the inferior leads. And another thing comparing with the sinus ECG is that the lead 3 and the lead AVF, here the QRS is upright. So in the sinus ECG, the QRS is negative. So, and the P waves are very much not clear. We were maybe they were in the ST changes. The ST changes may be related to the P waves. So then we have taken up this child for the EP study. During the EP study, this after the catheter insertion in the LA view, the CS catheter, the CS78 was at the os, CS os, and we have used 4 catheters. When the RV catheter is in the RV septum, and the right atrial catheter is at the high lateral RA. So during the EP study, with the atrial extrastimulus testing, we were giving drive cycle beats at 600 milliseconds. With the drive cycle at 600 milliseconds, we can see the widening of the QRS with the LBV morphology in the V1. So when we look at the But this can be either due to aberrancy or axillary pathway, but we can see that the HV interval is short. So it's mostly going through an accessory pathway. When we look at the 12-lead morphology of the pre-excited beat, so it's there's LV morphology with transition in the V4 with delta becoming with clear positive delta with QRS transition in the V4. Again, the lead 2 was upright and lead 3 delta was negative and lead AVF was showing a positive delta. With an extra stimulus, which is given at 320 milliseconds, it has blocked antegradally in the right side axillary pathway and was now going probably through a left side axillary pathway because the HV interval is again short with an V1 becoming positive and lead 2, 3 and AVF were negative, showing negative delta. So the axillary pathway ERP of the right side free wall axillary pathway was 600 320 milliseconds with probably a left posterior insertion of the left side axillary pathway because it is negative in the inferior leads. In the subsequent atrial extrastimulus testing at 280 milliseconds, it has blocked antegradally in the left side axillary pathway. You can see slight prolongation of the PR interval compared to the previous atrial extrastimulus. And it has blocked in the left side axillary pathway also, but we can see that this narrow QRS, apparently narrow QRS beat has echoed back with the earliest activation in the distal CS, CS12. So that indicates that there is a retrograde conduction through the left-sided axillary pathway. Apart from that, the high right atrial activation is little earlier than as expected. So, and also one another interesting that we can see is that the extrastimulus beat also has a short HV interval. Although in the intracardiac ECGs that we are seeing shows no apparent pre-excitation, when we look at the 12-lead morphology of the extrastimulus beat, we can see that from V2 to V4, there is slight slurring of the initial part of the QRS complex. So at this point of time, we were thinking there's probably an axillary pathway 3 also. So during the subsequent atrial extrastimulus, when we compare the extrastimulus beat with a beat with another beat, a second beat, which I have labeled. So the beat 2 has a normal HV interval of 36 milliseconds, but the beat 1 has a short HV interval. So actually, this beat 1 has probably echoed only through the right side axillary pathway, and it has conducted with which and blocked in the both right side axillary pathway left and the third axillary pathway. So comparing the beat 1 with the non-pre-excited beat, we can see that there are some QAs which have appeared in the lead 2, 3 and AVF, also in the lateral precordial leads from V4 to V6. During after the atrial extrastimulus, we have gone to the ventricular extrastimulus testing, and with a drive cycle at around 600 milliseconds, the earliest atrial activation retrogradely was seen in the high right atrial catheter. Along with that, the activation over the his catheter was also simultaneous, and also little later it was seen in the distal CS and CS12 and CS34. So probably this drive beat was going through right side axillary pathway and may also through left side axillary pathway and a fast nodal conduction till this point of time. And the extra stimulus, which is given at 300 milliseconds, has blocked retrogradely in the right side axillary pathway with HRA becoming late and also probably in the node. And it's now only going through the left side axillary pathway. And if we notice the His catheter, so what happened was there is a small deflection just before the onset of ventricular local ventricular activation. So that is probably maybe a His signal. With a VH, the interval was around 30 milliseconds. So we were not sure with the H happening just before the local ventricular activation. We were thinking more of an infranodal axillary pathway, but we were not very much sure of at this point of time. Then during the atrial program for induction of tachycardia, double atrial extrastimulus was given, and we have induced a narrow QRS tachycardia with a cycle length of around 250 milliseconds. There is initial wobble in the tachycardia for the initial few beats. So during that time, the VA interval was 80 milliseconds. Again, as we have discussed previously, the HV interval was constant despite with around 20 milliseconds, with the AH interval varying between around 100 to 135 milliseconds. So at this point of time, we were like more thinking of a vasculoventricular axillary pathway, because with varying of AH interval, the HV remaining fixed and the amount of pre-excitation being fixed, guides us towards a vasculoventricular axillary pathway. So at this point of time, we have 3 axillary pathways. One is a right-sided free wall axillary pathway with the bidirectional conduction with an axillary pathway ERP of 600-320 milliseconds. It was not participating in any tachycardia and was blocking retrogradely at 300 milliseconds. And second axillary pathway, which is a left posterior axillary pathway with bidirectional conduction, and the axillary pathway ERP was 600-280 milliseconds, and it was participating in sustained orthodromic tachycardia. And the third one is a vasculoventricular axillary pathway, probably bidirectional conduction. It was a bystander axillary pathway. So with the available EP characteristics, the right free wall axillary pathway doesn't require ablation because it's having a low risk antigrade properties, and it's not participating in tachycardia. And left-sided posterior axillary pathway requires ablation, and vasculoventricular pathway obviously should not be ablated. So the left posterior axillary pathway is ablated during ventricular pacing by transeptal approach. So during post-ablation testing, with the infusion of isoprenaline, again, the atrial extrastimulus testing was repeated with a drive cycle of 400 milliseconds. And then extrastimulus were subsequently given decremental atrial extrastimulus. At 300 milliseconds and at 240 milliseconds, again, when we see subsequently with the varying S2 to H interval, the PR changes, but the amount of pre-excitation and the HV interval remained same. So this is more in favorable towards the vasculoventricular axillary pathway. Another interesting thing is that after the extrastimulus, there was a junctional beat. Again, the junctional beat had short HV with same morphology as the third axillary pathway, comparing to the junctional beat. And when we see the junctional and non-pre-excited beat, again, there were QAs which are in the non-pre-excited beats have disappeared, were not seen in the junctional beat. Probably those disappearance of Q waves is indicative of pre-excitation. So, and for right-sided axillary pathway, with induced AF during the post-ablation atrial extrastimulus, it was only conducting through the node, after that through the vasculoventricular, but was not going through right-sided axillary pathway. So we did not ablate that pathway. And with regards to the management of asymptomatic pre-excitation, depends on whether the patient has in a high-risk occupation or is a competitive athlete. So if it's not, then the guidelines, we can go for either exercise test or for risk stratification. Risk stratification by invasive EPS is a reasonable option. So our child already has an indication for EPS. So with this peri of less than 250 milliseconds or axillary pathway ERP of less than 250 milliseconds or inducible AVRT, it's a strong indication for catheter ablation. If none of them are there, just a clinical follow-up with awareness about the symptoms is a reasonable option. But catheter ablation may also be considered after discussion of risks and benefits with the patient. Thank you.
Great case. So over to the moderators.
Thank you. I think excellent case. And I must compliment Lars for a wonderful conference and very nice selection of cases. I have a couple of points. One thing is that you call it a posterior, left posterior pathway that you ablated. But the earlier sacral activation was seen in the distal CS, if I'm not wrong. So why don't you call it left free wall pathway?
Yes, sir. The one thing is that our CS catheter was not as seen in the initial part. It was only not completely reaching into the complete distal CS. It was. Okay. So that is one thing. And the 12 lead morphology was showing lead 2 negative, lead 3 negative, and lead AVF also negative. So that was more pointing us towards. So
And second thing is that there might be some difference of opinion about the ablation of right-sided pathway in this case. Is it possible? Because I think the ERP was 320. Is that right? 600, 320.
600, 320.
Yeah, that's a bit borderline. So once you are in there, all the catheters in place, there might be a difference of opinion about whether we should have gone ahead with the, because is it possible that this can produce a SVT subsequently?
Because even with the isoprenaline, there was no
induction.
There was no induction of tachycardia, and the ERP was 300 milliseconds. So, and being a small child, we decided not to ablate at that point.
Okay, that's fine.
Yeah, beautiful case. So first of all, I'd like to congratulate you for holding your urge of ablating another pathway in this case. This sometimes becomes such a measured and a calculated decision. And as Dr. Saxena said, maybe it might happen tomorrow, but nobody has seen tomorrow. So, who knows whether this patient will have that tachycardia. And, every 5 extra minutes we spend in the heart, there's always a risk of, damage, trauma, phrenic palsy, AV block, tamponade, all those things. So great job with holding your urge of ablating that pathway. Now, few things, this is a beautiful case, again, great teaching case where, you sorted out multiple retrograde activation sequence, one going over the right-sided pathway, one going over the left free wall pathway. And I'm sure you have just shown us the highlights of this whole case. But say when you first, placed the catheters and started pacing from the RV, or if you attempted your first para-Hessian pacing, what was the initial retrograde activation sequence? Was it always over the left-sided free wall pathway, or it was going over the right free wall pathway, or how did you see it?
So during the ventricular burst pacing, we initially have seen in the right-sided HRA catheters the activation, and then we usually start at 363, 70 milliseconds and 360 milliseconds, and then when we were going down, it has blocked in the right side and was going only through the left, and the activation changed to the distal CS. So we were thinking, oh, she has 2 pathways. Then again, with the atrial extra stimulus, and when it blocked both in the right and left, also we have short HV. So that made us think about another pathway.
No, that's fantastic. Now, how was your, this is very clear that you have a left free wall pathway here. What was your mapping strategies for this? Because with the pacing, sometimes even on the first beat on the screen, you have fusion, right? Or the right and left sided, over the right sided pathway and the AV node probably. But on the VEST beat, the S2, you're getting clear conduction over the accessory pathway, retrograde conduction over the accessory pathway. So how was your mapping strategy for ablating this pathway?
Ablated during ventricular pacing, sir.
Okay, VEST or straight V pacing?
Straight V pacing. With straight V pacing, with the local VA interval we were looking, and so we had to pace at a faster cycle length to see more of a conduction through the left-sided pathway, because we were pacing from the right ventricle. But there we can clearly see the VA fusion and a small pathway potential, so we could ablate, and there was ablation was successful within 2 or 3 ablations. Last.
Oh, that's great. I'll be curious to see that.
Tachycardia, there was no fusion. I think you could have done that also.
Yeah.
Yeah, we could have done during the tachycardia also, sir. But it was faster tachycardia, so we were.
That's fine.
Yeah. Sometimes with tachycardia or with rapid V pacing, when you're doing it, the blood pressure goes down. It becomes a little bit tricky to do it. And once you ablate, if the thing break, the pathway is gone, the catheter can also get displaced. So you can even do it with VEST, which is a little bit slower, and you can do it in a more controlled manner. Now, once this was done, did you again? I'm sure must have looked at the retrograde activation sequence, right?
Yes, we actually had the slide, but because of the limitation of the slides, I didn't.
Yeah, that's fine. Yeah.
So at 280 itself, so initially it was going through a left-sided pathway, and now it has blocked. And at 260, we have reached the VERP, sir.
That's fantastic. No, beautiful case. I would have just been curious to see the para-Hessian pacing with 2 retrograde conducting pathways along with the fasciculoventricular pathway. How that would look like would have been very fascinating to see. But regardless, beautiful case. And again, congratulations for holding your urge on ablating that other pathway.
Abhishek, you know what? I think his mentor Raja must be around. such a great case. Raja's inputs, are welcome if he's around.
Ullas, I would
Sir, you're welcome.
I missed the point. Was the ablation by the trans-aortic route through a foramen ovale, transseptal? How was it? I probably missed it.
Transseptal, they did transseptal.
So you did the transseptal already with a catheter in the aorta to guide you, or without a catheter in the aorta to guide you?
Transseptal without catheter in the aorta, sir.
Okay.
We did only with the RV apical pacing, sir. We didn't go.
No, you did the transseptal puncture. You did the puncture, or there was a foramen ovale?
Had a foramen ovale, sir.
You had a foramen ovale for patent.
Yeah.
Because otherwise, sometimes stimulating the left ventricle, you can stimulate in the left ventricle free wall. You could have stimulated at a much lower rate,
right,
and had a much more stable catheter position while mapping rather than stimulating the right ventricle.
No, great point. Another point you need to do just as a teaching point is that when you ablate a left free wall pathway, and if you're pacing from the RV, it is so far away that even if you damage it, sometimes you may appear that you have lost conduction. So again, as Dr. Lokhandwala said, pace very close to the pathway from the LV side to make sure there is no conduction going from the LV through the pathway to the atrium.
Another way to make sure when you don't have another access to the LV is to pace from the distal RVOT. If you pace from distal RVOT instead of RV apex, you have faster activation of the LV free wall. So you're a little closer in terms of fiber orientation if you pace from the distal RVOT, which is why if you have a PVC from the distal RVOT, you have more of a negative component in lead one, right? So that can be used for mapping pathways on the left side.
Can I ask the panelists one question?
Jenny, please.
So one we said it was a septal pathway and the A was a little lateral. Maybe it was a slanted pathway and the ventricular insertion was more septal than the atrial insertion, and that would explain why it makes sense to call it a left posterior pathway, although the A might have been a little bit lateral, and that would make sense in the way that the pathways are normally slanted along the mitral annulus in that location. And other question was, there was one mention of the ventricular pathway conducting bidirectionally. I was curious as to how that was determined.
No, I think it was the right free wall pathway which was going bidirectional.
Oh, okay.
But not very sure.
Abhishek, I think they distinctly said that Dinakar distinctly showed the diagram where he said bidirectionally conducting vesiculoventricular pathway. Because of the
bidirectional conducting right and left pathways.
We were
both
not
the right sided and the left sided were conducting bidirectionally. That's what I understood.
Yes, sir. Both were conducting bidirectionally, both right-sided and left-sided. Only pointer for us maybe for a bidirectional conduction, the vasculoventricular pathway is this initial signal. We were attributing it to the His signal. So if it was His, which is occurring just before the local V on the His catheter, so it's probably going through the vasculoventricular pathway with the ventricular pacing at a drive of 600 milliseconds. But the other way is if we can see His activation before the right bundle activation, then probably that will give us more definitive evidence of retrograde conduction through the vasculoventricular pathway. We did not have that, sir. We could not get that recording.
Do vesiculoventricular pathways conduct retrogradely, or is that?
There were reports of bidirectional conduction in the vasculoventricular pathway. They have reported it as His activation occurring before the right bundle activation with the ventricular pacing, sir, with the septal pacing of the right ventricle.
But don't you think that is extremely difficult to make
yes,
out unless you have really closely spaced? You have 3 poles, but you require many poles and many unipolars to really identify that. And how common are vesiculoventricular pathways?
They're very common, sir. Of the atypical bypass tracks, only 1.5 to 2% of them are vasculoventricular pathways. So typical bypass tracks itself
Yeah,
are and of them.
Actually, there's an upcoming paper by Professor Anderson and the group, including my friend Eduardo, where they have done postmortems of normal hearts. About two-thirds of normal hearts have some form of vesicular, ventricular, or notoventricular pathways on autopsy. They're pretty common. Many times we see these ECGs with little, reported as pre-excitation, and you're not sure. They are actually more the rule than the exception, frankly. Two-thirds of normal hearts is quite a lot. Of course, all of them may not be conducting antegradally, but the presence of those vesicular ventricular pathways is quite common.
Thank you, Dr. Yash and Abhishek. Just now, Dr. Malini left, but her contribution was phenomenal to this webinar. So, ladies and gentlemen, the final presentation of this first edition of this EP Fellows Summit. And may I invite Dr. Jyoti Vijay, now the fellow of Dr. Narayan Mudri. I think he's also still around. She's going to be talking on transvenous conduction system pacing in a grown-up congenital heart disease survivor. Should be interesting. Welcome, Dr. Jyoti. You can share your slides.
I hope my slides are visible.
Yes.
A very good afternoon to everyone. Myself, Dr. Jyoti Vijay from Sri Chitra Tirunal Institute, Thiruvananthapuram. At the onset, I would like to congratulate and thank the organizers for giving us such an opportunity and for this wonderful initiative. So now I would like to present this case of transvenous conduction system pacing in a grown-up congenital heart disease survivor. So our patient is a 16-year-old 12th standard student from Tamil Nadu. She presented to us with a history of multiple episodes of dizziness and syncope for 2 months. And she's a diagnosed case of tetralogy of Fallot. After 1 year of birth, she underwent surgical repair of the tetralogy of Fallot. And after that, she was doing well. Now, for the last 2 months, she is having recurrent episodes of giddiness and 4 episodes of syncope. So this is a timeline of events. So 2006, she was diagnosed to have tetralogy of Fallot. And 2007, she underwent pericardial monocusp transannular patch repair and a VSD PTFE patch closure in 2007 in Frontier Lifeline Hospital, Chennai. And after that, she was having a reasonably good life without any symptoms. In 2022, she presented with the syncope. So this is a ECG. So we can see that there is clearly AV dissociation and third-degree AV block. There are more A's than B, and there is a broad, wide QRS escape rhythm with a right bundle branch morphology. Also, we can see that there are multiple splintered QRS, probably denoting the intraventricular conduction delay or a distal conduction system disease. So on further inspection of the ECG, on the rhythm strip, we can see that there is clearly AV dissociation, and the PP interval not encompassing the QRS is wider than the PP interval that encompassing the QRS. So it was measured as a 7-10 encompassing the QRS PP interval, and it was 8-10, which is not encompassing the QRS, suggestive of a ventriculophasic sinus arrhythmia response in the complete heart block. So here echo showed a good biventricular function. There was dilated RA and RV and a moderate pulmonary regurgitation. There was no residual ventricular septal defect. This is an X-ray showing channel bias and residual changes and prominent pulmonary artery. So you can see that she is a case of post-operative tetralogy of Fallot, now presenting after 15 years of surgical repair with a complete heart block. She's symptomatic. We have to do something. So what to do? So we have an option of a conventional dual chamber pacing versus conduction system pacing. But what are the challenges? We know that in presence of ventricular septal defect, the conduction system itself is weak. So the conduction system tried to avoid the defect and goes posterior in the membranous defect or anterior in a muscular defect. So conduction system itself is weak. So the risk of AV block is more, and post-operative further damage will aggravate the changes. And also it is estimated that the burden of these patients requiring a complete pacing or a pacing dependent more than 40% pacing is actually going to double in the next decade. So this is not just a single clinical problem, it is a public problem, public health problem. And also the risk of heart failure due to pacing induced cardiomyopathy is also longer and important considering the longer lifespan, as well as they are having the risk of developing a right ventricular dysfunction due to the progressive pulmonary regurgitation which is developing over the course. So there is the problems with the risk of ventricular dysfunction and ventricular dysynchrony. So what may be the best approach? So we know that conduction system pacing is coming up in like a lot of literature is coming up, and probably a best approach to physiological pacing. So, but is that feasible in this case? So we actually have to think about the feasibility of conduction system pacing in such a case. So we know that there will be a surgical patch in the ventricular septal defect. So the LV tunneling may not be getting a good result. Also, there can be fibrosis in the ventricular septum. Also, the conduction delay in this case are more distal. They will have peripheral RBBP. They will have more distal and diffuse conduction disease. And there is no clear case reports or data on hard outcomes in such cases. So after discussion, we decided to go ahead with the conduction system pacing in this case. And the ECG in the ECG in the EP lab, and we already discussed this. So showing a wide QRS escape rhythm, and QRS duration in this case was 174 milliseconds of the escape rhythm. So we liberally use a transthoracic echocardiography in this case. So we have used a 3D prober matrix array probe where we can actually have a facility for biplane imaging. So with that biplane imaging, we can see two planes, and we exactly localize with the help of 3D echocardiography the position of the septal patch and avoiding the patch in a 3D and optimizing the lead implantation. So by going by step, we have using the Medtronic C315 sheath, and we have tried multiple locations to identify the optimal location, and we want little more posteriorly avoiding the patch, and we got a couple of fixation beats also. So we gone step by step, and in our lab usually we will first check the unipolar tip and high to low output, then for the anodal capture for high to low output, and then bipolar. So all were very good threshold, less than 1 volt threshold we have got in this case. And this is the image showing the anodal capture. And we can see the transition from the LV septal pacing to the non-selective. And finally, we can see the septal selective left bundle capture in this one single strip. And the LV activation time in the V6 was 64 milliseconds. And the V6 V1 interpeak interval was 60 milliseconds. That is also very specific for the left bundle capture. So we can see the left LAO view showing the position of the atrial and ventricular leads. This is the AP view, and this is the RIO view. The final parameters is tabulated here. So in this case, we had achieved very good threshold. We can see less than 1 volt threshold for the left bundle unipolar, bipolar, as well as good anodal capture as well. And there is a good sensing also, but this location is not the first location. We have actually tried a couple of locations, and this is where we got the best parameters, and we liberally use the echocardiography. So this is that final ECG. You can see left bundle capture and narrow QRS, and the final QRS duration was 136. Though we expected a further reduced QRS duration, it was not possible, probably related to the intrinsic conduction system disease in this patient. After 120 days of follow-up, left bundle capture is still preserved. She is still having a narrower QRS, and she is clinically asymptomatic. This is a 3D echo view. This is a plaques view. So this is the patch. This is the one view. Actually, the patch and the lead are in a different planes. Only in certain views we can get both together. So this is the lead horizontally going, and this is the lead tip, which is attached, the attachment of the lead to the septum. This is interventricular septum, this is the LV, and this is the LA, and this is the VSD patch. So this is our case of post-operative radiology of fallow, presented to us with a complete heart block with a ventriculophasic response with the dilated RA and RV and moderate pulmonary regurgitation. So we had our problems as the patient can have the chronic dysynchrony, chronic pacing-induced cardiomyopathy, which may not be tolerated considering that she otherwise prone for developing a RV dysfunction over time. So we have done a left bundle pacing in this case, and at 120 days, there is preserved sensing and pacing parameters with good left bundle capture. So consider this, I think some learning points we get from this case is conduction system pacing is feasible in postoperative VSD repair or tetralogy of Fallot cases, but proper case selection needs to be done. And they have got a distinct challenges and advantages of conduction system pacing. Especially they may be the most deserving cases, because considering they can have chronic lifelong problems associated with the postoperative congenital heart disease. We also call it grown-up congenital heart disease. Like heart disease has not gone away, so it is just a grown-up. So the use of transthoracic echocardiography with biplane imaging and 3D echocardiography will help in appropriate positioning of the pacing lead. And over time, on our 120 days of follow-up, as an intermediate follow-up, we could see that a good left bundle capture with a narrow QRS is maintained. Though we have expected a further narrow less than 120, that was not probably possible because of the distal conduction system disease in this patient, which is probably uncorrected. And for each individual case, it's better to review the surgical records, see the long-term prognosis of the congenital heart disease, and what may be the technical challenges, and we should have an individual case-to-case decision-making. So to conclude, I would like to tell that these are just the scars of their constant battle to survive against their congenital heart disease which they are born with. So they deserve the best, and probably this is the best approach to pacing, and individual case-to-case decision-making or feasibility. If feasible, that should be the best approach, I think. So I'd like to thank for this.
Great case. Congratulations. Wonderful case. So one important point is that do you think it was just it was posterior fascicular capture? Because there are many case reports where people have attempted instead of that branch area pacing, they have attempted more distally. So it was either anterior fascicle or posterior fascicle. Thereby you can bypass the area of septal defect or patch. So this is posterior to the patch.
Yes, sir. So first thing is regarding a tetralogy of Fallot, by itself, their conduction system has got a yearly branching. The left bundle branches actually, it branches yearly and it is more posterior by itself.
Right.
Earlier histological studies have shown that they have got a yearlier bifurcation and it is more posterior, and they have got more interruptions. So along with that, this is a post-operative case. So she has got a probably a right bundle branch disease also. So we have gone more posterior and we have tried for a left posterior fascicle. So that I think.
Yeah, so it was a posterior fascicle capture problem.
Yes, sir.
And did you have to reshape the sheath, or it was that you just, it was like a hit and try at multiple places till you got good LVAT and all that?
We didn't reshape in this case because probably the RARV diagram was not very huge. It was RARV size was almost same as the LALV, so it was not grossly dilated. So I think the conventional C315 his sheath, it's a 43 centimeter sheath, that's well worked in this case.
Maybe a steerable sheath may be slightly better into position in different places.
Yes, sir.
Very nice case. I'm just still struck. Why did this patient have complete heart block? Because she was like many years after her surgery. It's kind of unusual for tetralogy of Fallot patients to get complete heart block, because the AV node is normally not involved in that condition. So did you dig deep to see why she had complete heart block, especially at a young age?
Yeah. So first thing I wanted to know whether she had a congenital heart block at earlier also. So she was not having at the time of surgery at 1 year of age. And after that, she was asymptomatic. And in fact, she was lost to follow-up. There was no rheumatological evidence of any rheumatological disease which was making her prone to familial congenital heart block. That is also not there. There is no family history of any rheumatological disease. And she herself is not having any other complaints other than this. So probably I think there's a chronic degeneration which has unfortunately occurred in this girl has caused this conduction system problem. And probably added to the post-operative problems.
Sure. No, that's nice. Now, when you were getting the RV lead in place, did you go into the outflow tract and then drop down, or how was your technique?
No, sir. We actually didn't go to the outflow tract. Approximately we have tried out the position of his capture, and then we have gone 2 centimeter distally, and through the guide wire through 331 we have tried to go a little more apical and then posterior, and then we have not gone to the outflow tract. We have using the wire, we have positioned our sheath C315.
That's great. And I saw lead 1 was negative throughout. Do you think it is just the rotation of the heart, or there was something else to it? If you see lead 1 at baseline during heart block and even with the pacing, lead 1 was very negative. So it was just rotation of the heart, you think, or something more to it?
I think it is a rotation of the heart. Even as evident in chest X-ray, there is a cardiac site is slightly abnormal than the usual position. Even in chest X-ray also, it is cardiac position appears slightly different than usual.
No, that's wonderful. And how did you program the device finally? What were the AV delays?
So in this case, he is in a complete heart block with symptomatic sinus bradycardia. I was not expecting for intrinsic conduction to be occurring. So we have programmed the AV delay at 120, patient and sensitively 80. So we have programmed like that. We have tried, in fact, multiple AV delays we have tried, and this is the one which I have given the best QRS.
No, fantastic. And then what were your other parameters? Not, you don't have to remember everything, but when you looked at other locations, you know, before you finally found this location, were you ever on the patch, or, you know, and did you screw it on the patch, or what else did you learn during the case?
We actually didn't screw it over the patch because through the echocardiography, patch was seen as an echo bright structure. So, and it was very, we are liberally use a 3D echocardiography also. So we could actually exclude the patch. We didn't screw over the patch, but a couple of locations we have tried it, but the threshold were actually in fact over 3. So probably there may be some septal scarring also involved in this case. So we have avoided that location and gone for the location with the wood. Couple of attempts we got it.
So that's
one
fantastic.
Avoid any fragmented QRS areas and all that. Low
Yes,
voltage
sir. We had low voltage areas and fragmented QRS area also, none of those attempts. And one of the attempts actually has gone little eccentrically. The lead has gone not perpendicular, it has gone slightly eccentric. So, and there also we're not getting a good threshold also. So we have changed. But in the couple of attempts, we got the good location and good threshold.
Fantastic.
Dr. Vijay, I had one question.
Sir.
You said that you selected several AV delays to get the best QRS. How would, when the complete heart block, how would changing the AV delay change the QRS? I'm not clear.
We didn't have much of difference, sir. We actually tried much because there was no significant intrinsic conduction occurring. So there was much of difference in between but we have tried to see any getting a better, narrower QRS. But we didn't get a much difference in each of them.
No, he's asking why were you expecting a difference? Dr. Yash is asking why were you expecting a difference by changing AV delay in a patient with complete heart block? That's what he's asking.
So that means if there is no intrinsic conduction, there may not be much change. But
exactly.
We have.
Except if there is a decremental conduction, then only it can happen.
Yes, sir.
So can I ask you one more thing about the AV delay? I think this is a very short AV delay. You know, when you have complete heart block, what you are looking for is the best E and A waves.
Yes.
You know, when you look at the mitral inflow. So if you look at echocardiographic studies, the best numbers you get is with 200. So, so you would a short AV delay is programmed in when you're trying to beat intrinsic, but you have no intrinsic. So I would keep a AV delay in this patient of 200 or 220. There is enough data with ECG and echo. So that is what you want to look at. You don't want to look at fusion, but you want to look at that. Okay?
Yes, sir.
And Nambudri is around. Dr. Nambudri is around, and of course, Jyoti spoke very well. Nambudri, I think your case established the fact that you could do in a complex congenital heart disease, typically in the staff, where the patch could be interfering, and you established it is feasible. But I think the end result, if you're looking at the kind of a QRS what you obtain and all that, I'm not very sure. Should you be really very happy about the outcome here? Only the time would tell. But I was wondering. I think you actually demonstrated it is possible to insert that Medtronic lead into the septum. Yeah. So you want to make some more comments about it?
It was not, to be frank, it was not technically very challenging. I completely agree that a subtle difference.
We can't hear you.
Nambudri, can you repeat, please?
Am I audible now?
Yeah. Maybe. Okay.
It was technically not very challenging, to be frank. We had to go through a couple of positions, exclude the scar territory, a low voltage areas, then get through that area which perpendicularity maintained. So it was not technically very challenging. And I completely agree with the point that AV interval will not make a major difference. I also would keep a little higher to avoid proper diastolic filling. That is the important point when you have no conduction through the intrinsic. In the AV will not have any change in the QRS morphology with any AV interval. But as Dr. Ullas suggested, this but small change in the QRS width and all would make a large difference in the clinical outcome. We need to see large number of cases, but I believe if always narrower is better.
Yeah. So anyway, number 3, I think that was a great case. It is just, we want we selected these cases not necessarily because of certain challenges or complexities of the devices. All these 8 presenters today we chose, and the moderators also helped us to choose. They actually encompassed the most of the EP issues and the device issues, and it was absolutely kind of a great learning, definitely for me, and must be to the most of the attendees. And I remain thankful to again the moderators. As usual, they have been patronizing such conferences every time I invite them. And I thank all those presenters, beautiful presentations, a lot of learning. And before I say good night, let me just announce that the 2nd edition of this IEP Fellows Summit is going to be on 27th of August, 2022. I hope most of us will return back to join. It's going to be starting from 5 p.m. to 9 p.m. on the Saturday, 27th August, 2022. And again, finally, I would like to say that my team, Dr. Anindya, Dr. Anand, several of the physician assistants, cardiac technologists, and they only, did all this job. They collected the cases and they put it up so nice. I'm thankful to all of them too. So, ladies and gentlemen, wonderful. Thank you very, very much, everyone. And I look forward to seeing you on the 27th August again. Thank you, one and all, again. Good night.
Thank you. Good night.
Thank you.